I'm right. We are live now, Chairman.
Thank you, Nick. That's most helpful. Thank you. Good morning. It's been a while since we last met as Healthy Staffordshire Select Committee, and really so much has changed since we last did. Last week, we reached a terrible milestone, that of 100,000 deaths in the UK due to the coronavirus within 28 days of a positive test. The pandemic has touched each and every one of us in so many ways with so much tragedy and sorrow. Therefore, I wanted to start this morning's Healthy Staffordshire Select Committee by paying tribute to all of our workers in the NHS, social care, and in those industries supporting communities to keep going, whether that be retail, food, manufacturing, or the voluntary sector. 2020 has been a difficult year for so many on the front line, and we wanted to thank you all for all that you do. It is the actions of individuals on the front line battling the pandemic who, by coming into every ounce of energy and their skills, will help us eventually defeat this virus. It is recognised, these efforts across our communities, and highly valued, and I'm sure everyone on this committee would echo these sentiments. Therefore, it is incumbent for all of us to continue to follow the government's guidelines of hands, face and space, and keep reminding people of these requirements both now and when they have been vaccinated. So on to this morning's Work Ahead Committee. This morning it is Monday the 1st of February 2021, and I am your Chair, County Councillor Jeremy Pert, for this meeting of the Healthy Staffordshire Select Committee. Can I welcome you all to the meeting? Can I also extend a warm welcome to all of our guests from Staffordshire CCGs, Staffordshire SDP, and from the Staffordshire ICS. And I'm sure they will introduce themselves as we move on through this agenda. But I am always reminded by how many senior colleagues from across the NHS take their time out to join this meeting and ensure that we are fully up to speed with what is going on within their sphere of activity. So thank you for setting aside this time for some really critical and important conversations. This meeting this morning is being delivered to you by the magic properties of Microsoft Teams, and I would remind all members of the committee to keep their microphones off when they're not speaking to make the discussion easier to follow and away from background noise. Second of all, please can I ask members to keep their cameras off when they're not speaking to protect the bandwidth for the rest of us to be able to follow proceedings, and please can you use the raise hands button if you'd like to ask a question during the meeting. I will try and pick everyone up, but if I miss you, apologies in advance. I have not scheduled a break in this morning's proceedings, but will do so for the next meeting. But if members feel that they need to take a break and come back, or have a prior commitment and need to depart, please can you let us know through the chat function so that we can ensure that we are quorate throughout the whole of this meeting. Thank you. So moving on to this morning's agenda, first of all, apologies. Can I have any apologies, please?
I have apologies, Chairman, from Ian Wilkes, Newcastle Borough Council, and Maureen Freeman, Cannock Chase District Council. Also, I understand Mrs Hughes from Staffordshire Moorlands District Council is having trouble joining us.
Thank you for that, Jonathan. Appreciate that. It's not on the agenda, but can I just confirm that we are quorate? There is a goodly number of us, so I see no reason why we don't have more than 6 members present. But can I just ensure that...
Chair, we are amply quorate.
Thank you. Can we make sure that's on the minutes for this meeting, please, in due course? Then point number 2, declarations of interest.
Yes, Chairman, I've got a declaration of interest. Councillor Anne Edgeler, I am partner governor from the County Council on the MPT.
Thank you, Anne. Are there any further declarations of interest? I will take silence as a reason for moving on. So moving on to the minutes of the last meeting held on the 30th of November. For those of us who were there, firstly, are they a true and accurate record? Can I have a proposer and seconder if that is the case?
Yes, Chairman.
Thank you, Anne. A seconder?
Second, Chair.
Thank you, Tina. If we can vote in the negative, if people aren't in agreement, can they signal? Otherwise, I will take them as a true and accurate record. Thank you. So secondly, in terms of matters arising from those minutes, can I just ask Jonathan or Nicholas, the West Midlands Ambulance Service proposed to provide some additional information in terms of performance in the rural areas. Do we have that?
Chairman, we don't yet, but we are following it up.
And in so thanks, Nick. And in so doing, could we also just check whether there has been further dialogue between the ambulance service and the first responders as per the agreement at the last meeting, please?
There hasn't yet, Chair, but I will follow that up. I'll take that as a note forward.
That's really helpful. Thank you, Nick. I appreciate that. Is there any other matters arising that people want to pick up? So now on to item number 4 onto the agenda for the day, integrated care system delivery plan. So first of all, let me apologise for the quality of the printing material that members have had. Some of that was missing some of the words, so apologies for that. We'll ensure that going forwards that that gets picked up. Secondly, clinical commissioning groups were established back as part of the Health and Social Care Act in 2012. So replacing them, or the proposals to replace them, are something that happens once every 10 years or less. So I think this morning's discussion on ICS is a really important one to get right for our residents. And I have asked Prem Singh and his team to introduce the subject with a presentation of 10 minutes and no more, so that we can have the maximum time to scrutinise the proposals. I would hope that by about 11 o'clock we were able to move on to the vaccine rollout, but I would like to guillotine the session at the latest at 11:20, and I'd prefer the discussion to be based on discussions from the floor rather than going page by page through the reports. So with nothing further ado, Prem, let me hand over to you and your team. Would you like to start off with introductions, and congratulations on your appointment?
Thank you, Chair. Good morning, colleagues, and just some very quick introductions. And joining me in this first session about the ICS is Simon Whitehouse, who's the SDP Director. We've got Peter Axon, who's the Chief Executive Combined, here to talk about PLACE. Say hi, Peter. We've got Marcus Warnes, who's the Accountable Officer of the CCGs. We're supported ably, Chair, by Tracy Shewan and Tanisha, who's going to put up the slide deck. Tanisha, please. We will get through this presentation fairly quickly, Chair, as you said, so we've got time for question and answers. And some of us will be leaving you at when you come to the next item around the vaccination programme. So next slide, Tanisha, please. So this slide, Chair, is intended to demonstrate the evolution of the integrated care system and where we started off across the NHS with STPs, Sustainable Transformation Partnerships, established in 2016, in fact, where if you like, the key drivers were that given the changes in demographics, the increase in morbidity and comorbidity, leading to rising demand outstripping resources, meant also that we had some significant health inequalities to manage, and that couldn't be done by any one single organisation. And then came in 2019 the NHS long-term plan, which then translated into the next box, if you like, is the SDP for Staffordshire Stoke-on-Trent, producing its case for change, identifying 3 or 4 key big areas for us to tackle together. The first was to improve health outcomes. The second, to tackle the wider determinants of health and inequalities. The third, to improving the care experience. And finally, to get the best use, if you like, in terms of productivity of the Staffordshire Stoke-on-Trent pound. Supporting all of that, as you will agree with us, is absolutely the need for us to support all of our workforce in terms of their resilience and their experience going forward. All of that, as I said earlier, in the original thinking of the SDPs, means that we can't do that alone. We rely on the partnership across the integrated care system to work together. The next box, whilst it's appropriate in terms of timeline, Chair, that it came the NHS engagement paper on integrating care that I believe you've been furnished with a copy. It came out in December 2020. Essentially, the next two boxes, I think, show the continuum, if you like, of the development journey of STPs migrating to become what's called to achieve an ICS status. And it's really important to draw a distinction between the aspirations in the Integrating Care Next Steps paper, which is for primary legislation, hopefully, to be going through during the coming year for ICSs to have a statutory footing by April 2022. The final box in this journey demonstrates that over the last few years, the NHS has set out a plan to get each ICS to be confirmed in the ICS status. That's simply demonstrating the maturity of leadership to take forward the plans in each area. And the national paper, if you like, that's come out now in December 2020, it reinforces all of that and placing it much more on a statutory footing. The four key purposes in that paper are again very much in line with the kind of journey we've all been on, and that's to improve population health, tackle inequalities and unequal outcomes and access, improving the value for money proposition, and very clearly, I think, expecting the NHS to support the broader social and economic development, working closely with local government and health and well-being colleagues. Just want to stress here, Chair, that therefore the timeline for April 2021 is not a new thing. I believe this committee has received from my colleagues in the past the development of that which has been taking place over the past year or two. And this is a staging post. It's not an end in itself. It's a means to an end to bring effective partnerships to deliver all of those aspirations. Next slide, Alicia, please. I'm, Chair, not going to go through the list of long-term priorities that are listed in the case for change for Staffordshire Stoke-on-Trent. I think suffice to say that many of these have been, despite the very challenging time in the last year, a very difficult time for our staff, many of these priorities actually, in fact, have been accelerated during COVID-19, where clinicians and professionals have sought to work really closely together with the service user at the centre of their attention, casting aside organisational boundaries. We heard in this last month at the board of the Shadow ICS the example of support to care homes and how health and care have been working really closely together. And in a bit, you're going to hear about the fantastic vaccination programme across Staffordshire, Stoke-on-Trent, which is another very good example of collaborative working. And that's what I think all this is about how we work together to serve our communities. I'm going to hand you over to Peter Axon.
Thank you, Prem. Tanisha, if we could move to the next slide, please. Thank you. So I'm just going to talk very briefly about the place agenda, which I think we collectively see as being at the heart of how we're going to address the various challenges that Prem mentioned a moment ago. So the first thing I'd say is that place isn't a new construct in terms of health and social care delivery. For many years, it's been an objective, perhaps achieved to varying degrees, though. So maybe 20 years ago, some will recall PCGs, primary care groups in the NHS. The basic premise of those was to deliver at that local place level. So there is an acceptance in this process that solutions need to be localised, solutions need to be bespoke to address local need. And in that regard, perhaps I'll extract the box that has reference to neighbourhoods on this page. For us, this is absolutely the priority in how we want to focus attention, accepting that the ICS will be a system-wide piece, i.e. a county-wide piece. We need to ensure fundamentally that those county-wide objectives defined through the JSNAs that we have seamlessly are allocated down and through and delivered at neighbourhood level, whilst of course appreciating the importance of things such as the health and wellbeing boards and oversight that's appropriately required through them. And local authority footprints we expect at that lower tier level to align through to our what we're terming as integrated care partnerships, those place-based arrangements that we have across Staffordshire. If we could just quickly go to the next slide, Tanisha. This next slide shows the timeline, so what we've achieved to date. With, as you can see there, the ambition from April is to have shadow integrated care partnerships, place-based arrangements existing within Staffordshire, three places, north, south, east and south west, and an ongoing commitment from April beyond to develop and evolve the various frameworks and arrangements required to, as best we can, devolve as much as possible through to those neighbourhoods, those local service delivery offers. I'm happy to take any questions later on, but for now I'm going to hand you over to Marcus, if that's okay.
Thanks, Peter. Next slide, please, Tanisha. So as Jeremy said at the beginning, there's another period of fairly significant change about to be undertaken by the NHS over the next year or two. And I think one of the things that will be different is commissioning. So CCG's roles, responsibilities, statutory functions being absorbed into integrated care systems. And the document that Prem referred to earlier, the Next Steps document, talks about that happening from the 1st of April 2022. Some fairly sort of significant changes, which we will be working with system partners over the next year or so to implement. In terms of what will be different, commissioning in the NHS tends to be about sort of very transactional approach, around buying stuff on an annual basis. It'll very much be moving towards a long-term approach to planning using population health management, which is about building infrastructure with our local authority and provider colleagues, about intelligence, having the data in one place that we can collectively use to map the needs of our populations going forward, and then collectively agreeing the right interventions to deliver those outcomes. It will be about developing health and care outcome frameworks, and at the heart of this will be about addressing health inequalities across the system. Inner city Stoke-on-Trent is very different to rural Seaston, and we need to recognise a one-size-fits-all approach isn't going to be the best way of addressing that. It will be around building on the good work we've done with our local authorities to date around integrated care commissioning, as evidenced in our Better Care funds. And we've done some really good work around out-of-hospital care, discharge planning, meeting the needs of our children and adults. And we need to spend the Staffordshire and Stoke-on-Trent pound once between us, and some good examples of where we've done that well. The CCGs will be devolving a significant amount of their current functions and responsibilities down to place level. That means not just the responsibilities and the budgets, but staff as well. So potentially 2/3 of CCG staff will be working with providers and local authority colleagues and other partners through our integrated care partnerships. And we will also need to streamline our commissioning arrangements. We have 6 CCGs at the moment, and we are currently in the final stages of asking our member practices to vote on merger. The merger vote closes at midnight tomorrow, and assuming that all 6 CCGs vote to merge, we'll be submitting an application to merge to NHS England by the end of March, and working with NHS England over the first 6 months of next year to merge the CCGs. Next slide, please, Tanisha. And then just to conclude, a single strategic commissioner across Staffordshire means we can step back and very much let partners work on a place basis to put the right pathways of care in for their local populations. It will enable us to work much more closely with the health and wellbeing boards, speaking with one voice to deliver the priorities of the health and wellbeing boards, using population health management as the means to do that. And given that 92% of contacts with the NHS come at GP practice level, we are very much looking to devolve responsibility to the people who work with our citizens, our patients at a local level, to make right decisions around what works best for them in terms of health and care. I'll stop at that point, Chair.
Thank you.
That's the last slide.
Thank you. Thank you, Prem. Thank you, Peter. Thank you, Marcus. Let me hand over straight away to Charlotte Atkins.
Thank you, Chairman. Well, yet another NHS reorganisation. I think from the point of view of my residents, they want to know what difference it will make for them on the ground. You know, to take an example in Peter Axon's place, you know, will it be possible for local authorities and the health service to actually cooperate so a community mental health project like Nivden can continue? Likewise, you know, again, my local residents will be interested in the fact that they've had a minor injuries unit closed for 9 months. Will that make any difference? Because it seems to me that that's what people want. They don't want yet more committees, yet more name changes, and yet more structural changes. They actually want changes on the ground. And the other question I would ask is, you know, if we're talking about integrating the NHS and social care, will that mean integrating budgets? Because if we don't integrate budgets, then each organisation will be defending its own budget, and we'll still have the same problems that we have at the moment in terms of who's responsible for paying for who, depending on what setting they're in. So I'd be interested to know how it's going to look different for people on the ground who are suffering from NHS cuts right across the board.
Thank you, Charlotte. Who is going to pick that one? Are those two up, please?
I can initially respond if that would help, Prem.
Yeah, sure. Go ahead, Peter.
So thank you for your question, Charlotte. I suppose using the example of Nivden, I very much see this process as something that will pull together partners in any given part of the county to fundamentally understand what service options are available and the nature of the challenges for the local population, inequalities, etc., etc. I think at the moment, although we try and achieve that, I think there's still a long way to go. If I'm being brutally honest, there's also a long way to go in terms of understanding each other's challenges and how we can support one another. And I don't necessarily see that as being achieved through the bringing together of budgets, as in the legally bringing together of budgets. But if we can be fully open, honest, transparent with one another in relation to the challenges that we've got coming up, both in terms of 21-22 and beyond. And I think we will be better together. Pardon the pun, pardon the phrase. I appreciate that that's the system's strapline, but I think we can operate better together. But we need to be fully transparent, and trust is critical in all of this, trust across partner agencies. We all have massive challenges coming up, whether it be financial, clinical, social. We know that COVID's going to leave a huge burden for many years to come. And I genuinely believe if we work together, we will better address the various challenges that we have. We have loads of high quality services out there. The bit for me is ensuring that we join them up and we signpost and support our citizens in the best way we possibly can, which at the moment I don't think we always do. Happy to hand back, Prem.
Chair, if I may just add to that, I think when this paper, the engagement paper came out in December, the Health Service Journal headline certainly was CCGs to disappear, and a reorganization, as you said, Charlotte, about commissioning being subsumed into potential statutory ICSs subject to primary legislation. But if you read the paper, I think it's really important that we stress, I've stressed in terms of my role as the chair, that the paper is much more than CCGs, if you like, going and the functions being subsumed into ICSs. It is much more about place. And in terms of place, let's be honest, the kind of agenda you're talking about, Charlotte, that's where this needs to feature. You know, our communities, our service users and our patients don't recognize the SDP or, in fact, the ICS. Let's be totally honest about what they do recognize is their street, their neighbourhood, their GP practice, their school, their local parish council, their local borough council, you know, the local health and care services that can be joined up, as Peter has said. I think they're the significant opportunities we have to play for in this paper. If we get that right, which is why I think it's really important we talk about place more than we do about, I would argue, about ICSs. That might sound strange, Chair, coming from an ICS chair, but my emphasis is let's really drill down at that level. And in terms of resources, whilst they may not be formal coming together as far as we can see of health and care budgets, I do believe, in my experience elsewhere, there are many flexibilities that are available to us. For example, through Section 75 payment arrangements, where we can bring health and care resources and budgets much closer together. It's a question of our will and how we work collaboratively as partners to make that happen, Chair. Thank you.
Thank you, Prem. Simon, I noticed you indicated, did you want to add anything to what's already been said before I bring Charlotte back?
No, I think they've added those points, Chair, so happy to come in shortly.
Thank you. Charlotte, do you want to...
Yeah, well, perhaps I ought to be grateful for the CCGs going, because at least it means that the 5 years of misery in North Staffordshire for those people with hearing loss has now come to an end, because obviously you finally, after 5 years, done a U-turn, so that the people in North Staffordshire who have been denied free NHS hearing aids for 5 years are now going to get them at long last because of the misery that has been caused by Marcus and his crew. So I should be grateful for that. But my concern
Charlotte,
is, my concern is that, you know, you talk a lot about reorganisation, but, you know, is it going to take? It's going to take what, another 2 years before we are talking about place. And that's about, you know, what happens with every reorganisation. There's a hiatus for 2 years. And what worries me is that, you know, we have a lot of talk about this, but when are we actually going to see the changes on the ground? That's what people are really concerned about.
Thank you, Charlotte. Simon, I notice you're indicating, could you just talk a bit about the Shadow ICS board as well as that sort of whole communication in public stuff, please?
No, absolutely, Chair. And I want to pick up on a couple of points that Councillor Atkins has talked about as well. Firstly, though, just let me say thank you for your comments right at the start of the committee meeting, Chair, and I will make sure that we'll cascade that through to NHS and social care colleagues in terms of that recognition and the comments that you made. So genuinely appreciated and noted. So thank you for that. So a couple of bits. Look, we don't need a reorganisation to deliver integrated care, and actually our conversation should be, as Councillor Atkins flagged, what changes are happening on the ground, not about what does any reorganisation that happens behind the scenes takes place or changes. And some of this is about our collective ambition. And you know that I've been to this committee several times and talked about some of the steps that we're taking and some of the things that indeed have happened, and we need to keep building on that. And we need to keep having that challenge and that honest conversation of what's changing for the resident, whether you be in Newcastle, whether you be in Leek, whether you be in Tamworth, whether you be in Burton, wherever you are. I think there's a few elements of that, though. So we still have the Health and Wellbeing Board as statutory subcommittees of the council with a responsibility to drive and support the delivery of integration. We need to make sure we've got the priorities aligned and we've got a real focus on that. We know that the aftermath, so currently dealing with COVID and the aftermath of COVID, is going to require us to work differently, to think differently, and some of the rules that we've had before, we're going to have to just lift up, throw away that rule book and be really ambitious about how we tackle some of the population health and equality challenges that we've got. And we'll need to do that collectively, and we'll need to do that in partnership. And one organisation, whether that be an acute trust, a community provider, a GP practice or a local authority, is not going to be able to respond to the local community challenges that we've got and we are facing. Chair, in terms of the point that you asked me to raise cover specifically, we have got a shadow board that's formed, that's got the leader of the council and the chief executive of the council on for both Staffordshire and for Stoke-on-Trent. And then, as Peter's talked about, then the formation of the three ICPs is absolutely around local engagement with local communities, with districts and boroughs, as well as with the counties and with voluntary and third sector. We've got voluntary and third sector and Healthwatch recognised and with seats around the board, and that board will start to meet in public from February to drive that transparency approach, and that's one of the things that Prem, as the new chair, has been really clear about in terms of being accountable to and demonstrating our responsibility to local communities. But in terms of Councillor Atkins' point, it's about our collective ambition, and she's absolutely right to say what's the difference going to be, and we need to work together to demonstrate that, but we don't need a reorganisation, Chair.
Thank you, Chair.
Thank you, Simon. I'm going to move on to Bernard Peters, please. If you want to come back later, Charlotte, you'd be more than welcome.
Thank you.
Thank you, Chair. May I echo and associate myself with your opening comments and express people's gratitude to the NHS during these dreadful circumstances. Throughout the conversation so far, I've heard quite clear references to Stafford and Stoke-on-Trent. My division is East Staffordshire, Burton-on-Trent, which touches Lichfield and Tamworth. I'd like to know how aligned you are with Derbyshire and the UHDB. I should imagine it's a common theme throughout. I think there was a mention of that, but I'm looking for some assurance that the master plan that we're talking about today does align with what's going on in Derbyshire, because there's a lot of people in East Staffordshire get a lot of care from UHDB, more on occasion, perhaps more so than Queen's in Burton. And my final point, there was reference there to the role of the CCGs. And I'd just like to make a point that I often try to reinforce every time we meet. I do hope that when this reorganisation comes out with GP practices and the CCGs, that you will look to utilise the patient participation groups more effectively. It's just been a tick box routine in my view and opinion. There's incredible skill base within my own PPG. And I would implore you to get a focus on PPGs and test them, not to ask them to be volunteers at car park vaccination centres, but to give them a meaningful job to do. And I would welcome assurances that you would perhaps be considering that. Thank you, Chair.
Thanks, Bernard. Prem, is are you going to pick up the first point and then see where we go to in terms of the PPG? Just for reference, about 60% of our residents will access some services out of area.
Yeah. Thank you, Chair. I'll let Marcus and others pick up the point about PPGs, but just to reassure colleagues that we're absolutely aligned with UHDB. So Cathy McLean, the chair there at UHDB, and Gavin Boyle, whom I know really well, are members, full-blown members of our Shadow ICS board, as is Duncan Bedford, the managing director of Burton Hospitals. So, and the other advantage, Chair, is in my other life, as you know, I'm a jobbing chair of an NHS trust in Derbyshire and work very closely with UHDB. So those connections, if you like, that we have. And I'm really now pleased to also add for your information that Cathy McLean, the chair of UHDB, has now been also appointed as the independent Shadow ICS chair for Nottingham. So we've got quite a bit in common about if you like, cross-boundary working, this work that goes on between Derbyshire and Nottingham, and Derbyshire and South Yorkshire, and Derbyshire and Staffordshire, as you well know, and the question has been raised on that point already. I think that gives us significant opportunities, I think, to do that cross-fertilisation and learning from each other. I think that's a tremendous opportunity in the coming period. Marcus. You're on mute, Marcus.
The first of many today, Jeremy, no doubt. Apologies, it had to be me. Just picking up on the cross-border working before I sort of cover off the PPG issue. Over half of our acute care is commissioned from outside of Staffordshire. So 20% of our patients go to UHDB, to Burton. So we have to work very closely with UHDB and with Derbyshire commissioners around the models of care. And UHDB will be part of 3 ICPs, and obviously we're just one of 3. So it's important we get that relationship right. And in the south of the county, we've got significant contracts with Royal Wolverhampton, with University's Hospital of Birmingham, largely delivered from Good Hope, with Dudley, with Walsall. So we do have a very complex system, and whilst people may live in Staffordshire, they do obviously go outside of Staffordshire for their care. So we've always had to work very closely with neighbouring commissioners, with STPs and ICSs, and with providers around how that care is commissioned and delivered. And where you're a minority commissioner in a contract, that can be quite difficult. But I think we do have good relationships there, and fully recognise the comments around patients who go outside of Staffordshire and the need to work with neighbouring systems. Whilst we tend to focus on our big within Staffordshire providers, we have lots of people going outside of Staffordshire. We can't lose sight of that. In terms of PPGs, I think Councillor Peters' point is well made. We have 147 practices delivering from about 154 different locations. Each of those have got a PPG. Actually, engaging and working with them all in the way we want to is actually quite difficult for 6 CCGs. I think coming together as a single strategic commissioner, with our providers working with our practices through the 3 ICPs, probably puts us in a better place to engage much more at a neighbourhood level with the issues that people are facing. So I do actually think the ICS place, working down to a neighbourhood level, is probably going to enable us to engage with local people more than we've been able to do in the past, as we strip out some of the layers of bureaucracy and actually using the principle of subsidiarity, actually devolve things down to the lowest level necessary, where you can make the right decisions that are very locally sensitive. You can't have a one-size-fits-all approach to Staffordshire and Stoke-on-Trent. We need to be much more sensitive to the very specific issues that our neighbours are addressing. And as I said when I went through the slides, I fully recognise that inner city Stoke-on-Trent is very different to Codsall and South Staffordshire, to Staffordshire Moorlands, to Newcastle. So we do need to make sure that whilst we have a more strategic long-term approach with our local authority partners to commissioning, we don't lose sight of those very different local differences in terms of how people live, where they live, and the services they need to receive to meet their needs.
Thank you. Bernard, do you want to come back?
Something just occurred to me as colleagues were talking there, Chair, if you will indulge me. I wonder if there's anything to say about the role of pharmacists in the plan going forward. They're very, very important, more so in the pandemic at the moment, but I do hope that they will have a part to play in all this. Is it possible just to give me a brief view on what the thinking is around pharmacists?
Yeah, if I could maybe sort of just quickly pick that up, Chair. One of the things that, as Prem said before, the next steps document, the headline might have been around the abolition of CCGs. There's an awful lot more in there, and there are significant implications for NHS England and NHS Improvement, who, whilst they share a chief executive, are 2 separate organisations that will come together. So a lot of what NHS England currently commission will also be moving into ICSs. And under the direct commissioning arrangements, NHS England do commission all 4 primary care professions, which is general practice, which is delegated to CCGs to commission on behalf of NHS England, but also ophthalmology, dentistry and pharmacy. So ICSs will have a much more role in a much more specific role in the commissioning of all 4 primary care professions, which will include pharmacies. And in the old days of PCTs, when I was a director of commissioning in a PCT, we held those contracts with pharmacies. They sit with NHS England at the moment, but they will, if the legislation is enacted, will come back to ICSs. So I think we'll be able to bring together some of the fragmentation of commissioning responsibilities into one place, which I think can only be good for our patient population.
Yeah, thank you, Chair. Thank you, colleagues. Thank you.
Thank you, Marcus. And obviously, community pharmacies sit around the table at the Health and Wellbeing Board, which is also scrutinised by the Healthy Staffordshire Select Committee. So we do have a role and responsibility as a committee as well. But good point. I'm just going to be unusual and invite Kath Perry if she's got a question in a similar area, so that we can pick up those similar areas. Kath, have you got something you want to just add in terms of out of area?
Yes, please. Last firstly, to what I've been listening to, you've touched on the north of the county. What about the south of the county? South Staffordshire, we're served by 3 CCGs at the moment. Stafford on the Penridge side, Cannock on the Great Worley Chesley side, and Seaston in the south of South Staffordshire, if that makes sense. We have cross-border as well. You've touched on Derbyshire, but we have a hospital in the middle of Cannock that is served by Wolverhampton NHS Trust, and we also have residents that go into Walsall Authority for their services to the hospital, Wolverhampton. Touching on the other side, we've got Birmingham. What about across borders in those areas? I seem to be hearing a lot about the north and Derbyshire and all of that, but I'm not hearing much about the south. I want to know where this plays out. And with these three STPs, where are the lines drawn there? In as much as we've got 6 CCGs at the moment, where are the lines drawn with the 3, please? Can you tell me that? Thank you. Thank you for indulging me, Chairman. Thank you.
Thank you.
If I just maybe start that one off. So as Councillor Perry said, if you take the Seaston Peninsula, for instance, and South Staffordshire, then the south of Seaston tend to go to Dudley for their care. The north tend to go to Wolverhampton for their care. So we have on all of our boundaries, it's similar in Newcastle, where a significant proportion of people choose to go into Cheshire for their care. So the outflows on all of our borders are significant, and we have to work, as we have been doing for some time, with our neighbouring CCGs, with neighbouring providers, and I think ICSs will bring together a number of those responsibilities that will make it much easier, I think, for us to have those discussions with neighbouring systems. So my apologies if we were focusing too much on UHDB in the east, but I do fully recognise the fact we have some issues in the south. I mean, I have a £100 million contract with Royal Wolverhampton, a £60 million contract with UHB for Good Hope. So, you know, we do work very closely with those systems, and we have to do. In terms of the other point Councillor Perry made around the boundaries, the southeast effectively will be Burton, Uttoxeter, Lichfield, Tamworth, Burntwood, and the southwest is Stafford, Cannock, the Seaston Peninsula, and South Staffordshire. So the way we've organised is very much based on not just where people live, but where they choose to receive their care. And Seaston Peninsula is part of South East Staffordshire CCG, and they will be sat in different ICPs. So I think having a single commissioner means we can get rid of some of the complexity of that and actually work much more on a place basis, perhaps much easier than we have done in the past.
Thank you, Kath. Did we answer the question?
Yes, thank you very much indeed. I appreciate what you said today. I'll watch this space away to see how it pans out. Thank you.
No, really important question. Thank you. Jill Hood, can I bring you in, please?
Thank you, Chairman. I'd just like to say that I really appreciate the question asked, re the pharmacist, by Bernard. Just a quick question for Marcus, who spoke of the 6 CCGs merging. Can I ask the single strategic commissioner, will that be a political appointment?
Who wants to pick that one up?
Yeah, sorry, I was on mute. No, it won't. Second time. No, it won't be a political appointment, no, but there will be the CCGs will need to come together. Assuming that our 6 memberships vote to merge, then we will submit an application for merger by the end of March. And then as the CCGs come together, clearly we'll go from 6 boards to 1 board. We'll need to look at the leadership of the CCG, because there'll be a process to making those appointments to the single chair, to the accountable officer, etc. At the moment, that won't happen until the 1st of April 2022, but there are some discussions at the moment around in-year mergers, and we'll wait to see if that happens. So there's an awful lot we need to do if we get a yes vote on Wednesday, on Tuesday morning, to merge a huge amount of work to create what's effectively a new organisation. But no, it won't be a political appointment. It will be, the NHS will be apolitical as it always has been.
Thank you, Marcus. Thank you, Chair.
Thank you. And presumably, Marcus, you'll be able to share with the committee the nature of the result when you're able to do so.
Yes, we will. I think that will be on either, I think it'll be Wednesday or Thursday once we know the outcome. The LMCs are validating the voting process, and we just need to give them time to make sure they've counted the votes and everything's been done accordingly in line with our constitutions. It'll be in the next few days, Chair.
Yeah, I don't think the committee was looking for anything in advance of what you know. It's just it'd be useful just to keep the committee up to speed with discussions here. Anne Edgeler, and then I'll bring in Paul Northcote, please.
Thank you very much, Chairman. Good morning, everyone. And I'd like to add my thanks to the NHS for all the good work that they're doing and all the staff and everything. It's really good, especially the difficult times we're going through. My question really is, this is so important. The NHS is so important to the general public. And I'd like to ask the question, what pathway are you going to use so the general public can understand what's happening to their health and well-being, please? Thank you.
Who is going to pick that up? Simon.
Thank you, Chair, and thanks, Councillor. I think that's a really pertinent and important question. So I would say we need to use every channel, don't we? So this being part of that engagement and that conversation that's taking place. But I reiterate the points that I raised when I was speaking and responding to Councillor Atkins' point. The really important bit, I think, for us is that actually this is about how do we focus on health, local authorities, voluntary sector, working together in a more integrated and joined up way for the interests of the population. This is not about saying we are throwing everything out of the window that's gone before it. This isn't about saying we're suddenly changing how all of our organisations work. It's about how do we support our clinicians and our professionals to work in as coordinated way as possible for the best interests and the best outcomes for the population that we serve. So moving the ICS board to meet in public adds to that transparency. Coming and talking to yourselves in terms of scrutiny, being part of the Health and Wellbeing Board conversation, and continually working with general practice community providers, whether that be MPF with MPFT, with both local authorities and with lower tier local authorities in terms of having that conversation. But fundamentally, this has to be a local community conversation about how do we deliver services that meet the needs of those local residents. And I would much rather us be having that conversation with colleagues and pushing that message than it being one of reorganisation and restructure and formal organisational change. Because as Prem's talked about, we can use as many different three-letter acronyms as we want, but actually they don't mean anything to the local population. What makes the difference is how do they access their care? Do they get their care in a timely manner? And do we meet the needs with the care that's wrapped around them? And do we support them to stay in their own home as long as possible, in as safe a way as possible? And if you end up in hospital, do we get you out as quickly as possible and as safely as possible? That needs to be the real focus of our conversation with local communities.
And do you want to come back?
Yeah, thank you, Chairman. Thank you, Simon. Yes, I just hope that, that we can put the message across to the public so they do understand exactly what's happening with their health service. Thank you.
And our plea, Chair, there would be that you help with that, Council, as part of your role, both as county and with at lower tier and with through scrutiny to really make sure we talk about the right things, Councillor.
Yeah, we'll certainly do our best, Simon. Thank you.
Thank you. Paul Northcote.
Morning, everybody. And I'd like to add my comments, Chair, to those that you made about the NHS, and our thanks to all the partner agencies in this very difficult time. Down to the integrated care, this is going to be huge for our county. It's going to need to be agile to deliver to all areas. Some will be have more strengths, some will have deficits, depending on which part of the county you go to. To have a fully integrated care, mental health is mentioned several times in this paper about the importance of mental health and the fact that it's going to be treated as equitable and on parity with physical health. Now, we all know that this will require significant investment funding to make this happen, to make this realistic. Is this an aspiration, or is this an actual possibility in terms of delivery? We'll need some better funding in terms, not just the NHS, but to have those negotiations with partner agencies to build in better budgets to facilitate this. This will be very important coming out of COVID, as we're seeing the effects of lockdown more and more as each week passes. But we obviously need realistic budget setting, as mental health notoriously has been the low part of the priorities, and in some instances it's been as low as 6% of the total budget. We need a more realistic figure if we're going to be serious about addressing the mental health difficulties and challenges that we face. Is there a commitment that this is going to be a serious proposition to deliver equity of care on par and parity with physical health? Thank you, Chair.
I think Peter's volunteering to pick this up.
I can begin, and maybe Marcus or Simon could come in a moment. So for a while now, for a number of years now, I'm really pleased to say that the centre, the NHS centrally, has recognised that challenge that you described, Councillor Northcote, and the fact that parity of esteem was arguably lacking in terms of mental health services. And as I say, a few years ago now, the mental health long-term plan was developed, which is led centrally by a lady called Claire Murdoch, who also is a chief exec of a mental health provider down in London, but has another role as NHS mental health director, executive director. The beauty of that, I suppose, on one level is that it provides funding over and above the standard sort of ring-fenced allocated funding to CCGs or ICSs, as they will be, in addition. So it is specifically for mental health providers. CCGs commissioners are audited each year on whether that money is flowing down to mental health providers or not. And equally importantly, what comes with that funding is a clear expectation on service development, whether that be community mental health services or inpatient mental health services. So myself, Neil, who's also on the call today, are tasked with delivering a variety of service developments and outcome-based targets. We were last year, we will be this year, and we will be next year and going forward. So, for example, next year, I think the Mental Health Investment Fund is in excess of £5 million for Staffordshire, which is fantastic. I would perhaps, I suppose the only caveat I would put on all of that is, of course, the challenge, which is the challenge across the NHS and social care, is, of course, the development of staff to fill those posts. So the money is brilliant, the funding is brilliant, but of course the ongoing challenges are ensuring that we've got the workforce to be able to deliver. But it is in essence a good news story, I'm really pleased to say.
Thank you. I think Prem wants to come in.
Thank you, Chair. I think Peter's covered that off really well in terms of the kind of national direction of travel and guarantee. I just want to echo, Chair, that COVID-19 and beyond COVID-19 will mean significant, I think, challenges in our communities and mental health. We're already seeing the kind of demand curve going up, as you will appreciate. So a really important question, Councillor Northcote. And I just wondered, Chair, if Neil Carr, our Chief Exec of MPFD, if he's on the call, I wondered if he'd care to comment on this point as well. Thanks, Neil.
Thank you. With your permission, Chairman. Thank you, Prem. I think Peter's covered it. The reality is I've never known a time when the NHS has prioritised mental health above where we are now. And I think Staffordshire, working with the CCGs, Combined Healthcare and ourselves, are absolutely clear on the priorities. So year on year, there will be greater investment, but I think we have to acknowledge, as Prem is suggesting, we may have to differentiate and prioritise that, because during COVID and post-COVID, I think we will certainly see increases in child and adolescent mental health. Nationally, there is a huge growth. How we will work alongside education is going to be absolutely paramount to me, Chairman. And I think what we are beginning to see is the impact of isolation, particularly in the elderly, and that's beginning to challenge our community services. What I can say, though, is through health management, looking at some of the health inequality issues, as a system, we're alive, we're aware of it, and we are prioritising the money as to how best it can be used. Thank you.
Thanks, Neil.
Thank you, Neil. Just before we go back, Paul, I think this is a question we should keep very much live for the work programme. Maybe we'll pick back up on some of the points that have been made. Paul, have you got anything you want to just come back on?
Thanks, Chair. Yeah. I would like just to emphasise and thank you, participants, for your answers to that. But I think also equally important that we learn from the lessons that we've seen during the last year, how much partnership working will actually help to deliver this. And historically, we all know the NHS hasn't been brilliant in terms of partnership working, and it's been very good in silo working. But we need to exploit that wider programme of what's available and the valuable support systems that are already there in the community that can make such a difference to everybody's lives on an everyday basis. So I would like to see a commitment also to that real joined up partnership working and being open for that facility to take place. Thank you, Chair, for my indulgence.
I see lots of people nodding. Who's going to pick that up? I think there was a very clear question. Is there a commitment?
So if I come in on that, Chair, if that's okay, really quickly, and I think your point, Councillor Northcott, is absolutely spot on, and I guess that's been what I've been trying to reiterate in terms of let's move away from the conversation about reorganisation or restructure and let's talk about how do we work in partnership. And I think that's partnership within the NHS, but I also think it's about partnership NHS and local authorities, and it's voluntary sector, third sector, local communities. I think there has been some really clear learning over the past 12 months. And let's make sure that we don't lose the really good that's come out of that, and let's build on, use that as a platform to build on. And for me, that should be our work programme and should be our conversation going forward. It's not about what three-letter acronyms, making a decision around what happens when.
Thanks.
Thank you. You made a suggestion to put it on our work programme in terms of how well the partnership is working. I think that's what I heard specifically in response. How would you suggest we did that, Simon?
No, I'm always keen to come and have the conversation with you, Chair, and engage in the committee. I mean, I think that the fundamental piece here goes back to actually Councillor Atkins' question, which is how are we delivering integration that makes a difference on the ground to the residents that we've all got a responsibility for? So I think it's about how do we get into exploring the partnerships and linking that to what does integrated care look like on the ground, and what's the experience that residents are receiving when they need health and care in their local communities. But happy to work with you and with your support team in terms of shaping what that might look like. But I think it's more than just looking at an individual mental health piece or a physical health piece. It's absolutely starting to get into what's the integration agenda and how are we delivering that.
Thank you, Simon. That's useful pointers for us as we go through the development of ICS, and we can talk about timescales. Prem, was there anything you wanted to add, or shall I go on to Philip Atkins?
Chair, I think Simon's covered my point. I wanted to bring in terms of workforce, I wanted to bring in the important role of the voluntary sector that Simon's touched on already. And I think the other point I'd make about integration of services in reality and how we keep a check on it and be accountable outwards, not only to our committees, to this committee, but also to our communities, is the fact that we have this last month started every Shadow ICS board meeting with a service user service integration story. So the last month, as I said in my introduction, we heard about the joined up care home support integration service in Staffordshire that also takes place in Stoke-on-Trent. So watch this space, more of that kind of, if you like, accounting outwards, if you like, to our communities, and by way of having our board meetings in public every other month. I think that's a golden opportunity to demonstrate not only to our communities, but I think remind the board what is possible when we really cast aside organisational boundaries, put our effort into common purpose, and really achieve some fantastic results in that way. Thank you.
Thank you, Prem. Thank you, Paul. Let's go on to Philip Atkins. Philip, good morning.
Morning, Chairman. Yeah, I was pleased to hear what Simon just said. Actually, that answered to some of it to me. I'm just going to do a quote that Lord Chris did. Health is made at home and repaired in hospitals. And if you refer to your paper on pages 47, 48, 49, 50, where you've got population health management, it talks about a person-based approach. And I've been sitting listening, and we'll focus on the restructuring and everything else. And I'm the former leader of the county council. This has been going on for 11 years, so you're getting there, but it's taking time. Simon, Neil, and I know people will focus on the individual buildings that there are and everything else, but it is very much health is made at home. And I think that's a role that councils can help you in at whatever tier, district or county. But I'm going to go on two particular ones. One is communication, because people have, Charlotte asked about how you're going to talk with the people in communication. They don't understand the National Health Service. They think it's one great big body, but not, as we know, umpteen partnerships and everything else. So I think communication and what Nigel Crisp said about health is made at home and repaired in hospitals, that message has to get out there and do personal responsibility. You cannot gorge yourself on food and become obese and then think that you're going to have a healthy lifestyle that some magic pill's going to put right. And at some stage, neither is there after COVID a magic money tree. There's been a lot of people talking about spending more money. There ain't any. It's going to have to be put into something else. So you're going to have to stop doing things as well. So your communication plan is going to be really key on this. How do you bring the public and the people along with you in the future? So, that's my question. Well done so far. You've done a lot. You've got a lot and had a lot of crosses to bear. I know, my previous role. But the next stage, I don't think the public realise that life is going to change radically, even with a vaccine, COVID. So I don't think they've even got that round the heads. So open to the answers. Thanks, Chairman.
If I pick that up, Chair, if that's okay to start with, and thank you, Councillor Atkins, and also recognise the support that you offered when you were leader of the council as well in terms of that. So note that and recognise that, and thanks for that. So I'm going to pinch a quote from somebody as well, if we're in the time of quotes. So I'm going to use a Duncan Selby quote, which is, "This is really what really matters is to individuals and to communities. I think we need to get into this is about a job, a home, and a friend." And our focus needs to be much more on how do we get the right level of employment and the right education to enable people to get local jobs that pay well, that enable people to own their own homes, and that they have friends and they have social contact. And for us, the health service, and that needs to be a key part of this conversation and this debate going forwards, not just from today. The health service will continue to provide care when you need that care, when you become ill and when you become unwell, but we'll need to make some difficult decisions around that, as you said, Councillor Atkins. But this is much more about a fundamental partnership and a real change and a real focus in how do we work differently with local authorities and different partners. So there's as much in this for me, for local authorities, as there is for the NHS, because I think our focus needs to be the job, the home, and the friend. And if we were able to do that for individuals across all of our areas, then actually we would have much better health and well-being in general for the population that we serve, and that would then subsequently lead to less demand on the health services that would follow on from that. So actually you don't need to make some of those really difficult decisions that you talked about, because actually we're using the resource that we've got effectively, because individuals are able to take responsibility. But we can't do that without getting on the front foot. So the prevention agenda, the understanding of what are we doing to tackle obesity, the green space planning, housing planning, is all part of that health and well-being agenda, and that absolutely we are absolutely reliant and need to be hand in hand with our local authority colleagues in that regard.
Can I come back, Chairman?
Please.
I think Duncan Selby, I met him, and quite right. That's why we've put, if you've got a job, that's the first step, and you've got a house, that's the second step, and then have a good life and everything else. Just to cheer you up, in my day job as a farmer, we've got to double world food production by 2050, and it doesn't look like we're going to be able to do that. So obesity might be cured by another way, but hey, that's a different topic.
Thank you, Councillor.
Thanks for your optimism, Philip. Marcus.
Thanks, Chair. I was just going to sort of reinforce the comments that Philip made and Simon made. I mean, my background's in public health and health promotion. I've worked for nearly 30 years in the NHS, and our failure to really sort of get stuck into the prevention agenda and addressing inequalities, is something that I think we do need to recognise. There's another point would be that something else we really need to work with our public sector partners on is the fact that we are anchor employers as well. And the NHS is what, the third, fourth biggest employer in the world. It's the biggest employer in most communities. And I think something that COVID has thrown into sharp relief is our workforce crisis that we have in the NHS. Something else, another area that I think we need to exploit is our role as employers in terms of how do we get more young people aspiring to go into careers in care. I mean, how many kids currently sort of in school in Bentley think they'll be a consultant rheumatologist, for instance? Probably not very many. So the inequalities of ambition, of aspiration, how do we actually get people onto pathways into health and care professions is something else that I think we need to focus on. We're not going to be able to attract people from abroad in the way we did previously. We're going to have to very much grow our own. So I think there's also something about one of the ways we address that inequalities agenda, and as Simon said, fulfil the ambition set out in the Duncan Selby quote, is how do we actually work with our local communities with local authorities, local enterprise partnerships, in terms of growing our own workforce and getting our young people into those career pathways in health and care, which from my perspective have been hugely rewarding, and people have said thank you to the NHS previously. Actually working in the NHS is it's a huge responsibility and hugely gratifying on a day-to-day basis in terms of the difference that we make to people's lives. So I think using the pandemic, and I think we have seen an increase in people wanting to get into careers in the NHS, whether it be clinical roles, nursing roles, healthcare support roles, managerial roles. So there's probably an opportunity there that we can work with our local authority colleagues to exploit over the next year or two.
Thank you, Marcus. I'll just stay on the same subject. Philip, I'll come back to you in a minute if you want to. I just wanted to pick up a couple of those points, if I may, please. So I think that COVID probably has exacerbated some of those differences in employment opportunity, and we're going to have to go further and faster to try and bring back some of the equality in employment and opportunity, because particularly when you look at some of the people who are sort of most disadvantaged from technology, and that has been exacerbated by lockdown and lack of access to physical schooling in school, despite the teachers doing a fantastic job. So I do think there's more we need to be doing on that. I think you're right about population health management is a key cornerstone to trying to actually reduce some of the inequalities. And it's interesting to note that there is a common language coming from some of the partners. So some of the words that you would use and say say are very similar to what the borough council or the county council or district councils would also say. But I think we also need to go and ensure that that language and those behaviours are much more common across the rest of the partners. You know, in the end, I think there is a huge role that needs to be played by parish councils, the voluntary sector, you know, community-led activity, because some of this, you know, whether it's things like social isolation or just, you know, exercise, can be driven from a very low level in communities. And we've seen that reaction, which came from the reaction to COVID. So I do think there is sort of, you know, a whole chunk of work and engagement that needs to go hand in glove with this, because otherwise potentially some of the stuff that could be done in communities will be missed. The only problem I have with some of this is that actually some of the preventative agenda needs to be front end loaded. So my question is really about how do we, when we have a deficit already within the Staffordshire health economy, a financial deficit within the Staffordshire financial economy, how do we invest to make sure that we do move to this not brave new world, because I don't think it's that radical. I think we require people to do something slightly different every day, and then we'll get there. But how do we front end invest in some of the prevention agenda, because without it, frankly, we'll still be trying to keep the dam up with more bits of mud that we're putting against the dam wall.
So I can come in initially, if that's okay, give people thinking time, because it is a tricky question. It's a fair point in relation to the ability to free up money when you have very little money. So I've popped into the chat an example of a piece of work that we're doing in the Northern Staffordshire ICP that's a rather technical term described as asset-based management, but essentially what it does is it looks at a relatively small area. So in the example that we're using, I appreciate it's a different local authority, but Burslem is being looked at. And we're evaluating all of the resources, whether that be NHS, wider community, voluntary sector, private sector resources in that area, and fundamentally linking those resources to the challenges and issues that local population has. The next step is to then ensure that linkages are drawn, relationships are drawn to understand how we can utilise those local resources to improve the health and well-being of that population, but do it from a cultural OD perspective as opposed to a technical exercise. The point being, as I described in the chat there, the kind of ethos that underpins the Wigan deal that some of you may be aware of, which essentially gets the community to take more ownership of its own challenges, of its future, of its health and well-being. Those are the basic principles interwoven into this exercise I'm describing. I suppose the reason I'm describing that, Jeremy, is because the cost associated with that for us is time, effort and energy of the people who already are employed, both within the public sector and to a lesser extent the private sector. Yes, of course, that creates a commitment. Yes, of course, that creates a vision, because people only buy into things if they think it's going to be successful, frankly, and if it excites them. But fundamentally, for me, it's those kind of initiatives and principles that don't take a huge amount of money, but they do take a bit of vision, they do take a bit of different thinking to be able to land effectively.
Thank you, Peter. Jill Hood, are you on this subject, or shall I bring Philip back?
I'm on this subject, Chairman.
Please come in.
It's a reply to Peter talking about the community taking ownership of their own well-being. Well, yeah, that's absolutely great for the majority of younger people who I've heard it said often by doctors who I know very well that they have Google patients now who will go to their surgery. They know what they've got. They know what the treatment is. They just want that prescription. But for the elderly, it's a whole different ballgame, and you're far more qualified to acknowledge that than I am. They're reluctant to hear anything other than to go along to their doctor and to speak to their doctor about their well-being. And I just think that the elderly population believe that their doctor is their NHS. They don't understand that it is, as described, a massive partnership of other services. So although I agree with what you say, I just worry about the older generation getting left behind Thank you, Peter. Thank you, Chairman.
Does anyone want to pick up any comments on that? I do want to guillotine in 7 minutes. Do want to bring Philip back, and I'm mindful that Bernard Peters also wanted to come back in. So could we be brief, please?
All I would say to that is, yes, I entirely agree. General practice is absolutely key to all of this. That local identity of the NHS. When people think of the NHS, they think of the GP practice and that big, huge acute hospital up the road. And I'm not being disrespectful to either myself or Neil, who run mental health services and community physical health services, but that's just the reality, isn't it? And we need to be mindful and respectful of that. What I would say is that the kind of Kaiser Permanente principle of the hospital admission is a failure. I appreciate that's a very broad brush principle, but there's some value in that, and ensuring that we, as best we can, work upstream. And general practice has a huge part to play in that more proactive upstream engagement with the local population. So I do recognise and understand and agree with what was said.
Thank you. Can I bring Philip back in just to close this part of questioning?
Yeah, thanks, Chairman. I think it is in the document, actually. There's quite a bit of good stuff at the sort of 47 onwards for a few pages about the model of care. And I think that there's a role for councils to play, but not for councils to do it themselves, but communicate with the public. And I'll just use a couple of examples, which I'll pick up on what Marcus was talking about, actually. It's a career. You know, I've got a daughter who wanted to do American pop, but ended up being a registered child nurse, and she's now works for the Youth Vending Service, and she's going around setting up your vaccination centres, she tells me. So she's drifted into it, but really enjoying the job and working with young people and doing everything else. And then I know somebody else who's become a personal trainer later on in life. And that's really a bit like the barman who sat at the end of the bar listening to everybody's woes and troubles. So that there are other solutions out there without us doing them or the National Health Service doing them in a far more expensive way than the people themselves can do. And when you talk to the personal trainers and ask them who's coming to them, because they're paying hard cash to keep fit. You know, some of you on this call might be doing that, you know, paying hard cash to go to a gym or have a personal trainer. But you're actually, it's somebody to talk to and get de-stressed and have some exercise and get the endorphins going in you and everything else. So rather than just we try and do everything for everybody, think outside the box, which Duncan Selby was always on about. And there's other ways of helping people to help themselves. And I think that's going to be after it. It's a tricky one on the comms strategy and how you do it. I went up and had a look at the Wigan deal. And what really wound people up was little things that you would never think of, like where the dustbins went. And then they could use an old library as a drop-in centre for a deprived area where parents could have parenting skills enhanced. They've moved on from that now. So I think it's about getting people together and having a community spirit. And that is the one thing Staffordshire's got in bucket load. It just needs channeling in the right way without people knowing, because they'll only fight back and tell you that you're a load of expletives deleted. Thank you, Chairman.
Thank you, Philip. We're looking to bring this session to a close fairly shortly. So maybe instead of responding directly to Philip, what we do is just take an opportunity, Prem, for you to summarise. I just did want to pick up a couple of thoughts from Philip's side of things, which was clearly there is a role for enabling and signposting for all partners. And maybe one of the things that as you go, you will come back with at some stage is just greater clarity on roles and expectations of your partners and stakeholders, because I think that is part of what we're discussing, you know, right the way through down to lower level in terms of what does that mean for individuals in communities, because I think this will take some community leadership at all levels, and trying to be explicit on some of that and signpost the way would be a good thing. So can I, the committee is asked to is asked to consider the information provided and to comment on the ICS proposals. Just in your response, Prem, can you just give us a view in terms of what the next steps are and what comments you want formally from this committee, if any, from today? Thank you.
Thanks, Chair, and thank you, colleagues on the call, for a fantastic discussion this morning, really. So in terms of next steps, as we said earlier, the ICS submission to achieve our ICS status by April 2021, alongside the 6 strategic commissioners merging into one, are 2 important milestones, Chair, in the next period. But I think starting right now, right up to April 2022, is a fantastic transition year where we hardwire everything we've been talking about around place, actually, and building it ground up. And the Wigan experience, when I've heard them speak, actually they started thinking quite strategically at council level and thinking about approaching the big acute trust and other NHS players. They found that actually it's what people relate to that matters, and what people relate to, as I said earlier, is schools, primary care, GP practices and pharmacies, as one of your colleagues raised a question earlier on. So it's really important, I think, we build up from that. I think our ask from this committee, Chair, is simply, hopefully, to see that kind of vision of the end point, not the means to the end of getting the status of the ICS or geographical boundaries and lines and where we draw lines, but it's more about a way of being and about a collective leadership in service of our communities. And I think that's an important essence and spirit that we're trying to work with your officer colleagues and with yourselves, that we really need your support on board, and we need the support of our community. So we've said a lot about, the kind of different relationship and different conversation we need to have with our communities. I think the NHS has been a bit guilty of being a bit paternalistic in the past, and we need to change that dynamic quite a lot. In terms of prevention, there's a huge amount we can do by shifting our mindsets, I think, in terms of how we work. A lot of patients that come in to be mended, as Philip said, into the hospitals. Really, the conversation needs to, the great opportunity there is about their lifestyle change, about smoking habits, drinking habits, obesity, and so on. And taking those opportunities, I think, to open up those conversations is a really good starting point. The final couple of points I'd make, Chair, is that the NHS and local government together are massive employers. We spend millions and millions of pounds. If we really worked together with a kind of mindset of investing locally, so if we really pressed hard on employment and how we could really make those differences in our communities, to, for example, employing youngsters from the looked after registers, in internships, people with a learning disability, and so on, we can, I think, make a lot of change in terms of employment within, as somebody said earlier, one of those factors. We also spend millions of pounds procuring services nationally. If we shifted the dial on anchoring what we spend in our local businesses, think about the impact that we will make in terms of socio-economic development here in Staffordshire, Stoke-on-Trent. Finally, on a very light-hearted note, Chair, if I may just share a personal hobby of mine, I love watching The Repair Shop on BBC. You're probably wondering where I'm going with this. The Repair Shop is where people take in things to be mended, a bit like the NHS. But actually, it's more than things being mended, isn't it? It's about putting lives together. It's about memories. It's about giving something back to communities. And I think if we can carry that principle, even from the mending perspective, I think there's a lot more we can do. I think that'll be a winner for the NHS. So that just shows you that I watch sometimes some stuff on television, which I think has got a lot more meaning to it in terms of families and value and memories than just being repaired. Thank you, Chair.
Thank you, Prem. Now, every time we watch the repair shop, we will think of this and your conversation. Just two things. Bernard, I noticed you signalled and then you gone quiet. Was there anything you did want to add in, or can I quietly take it that we've had your contribution? I'll move on then. So, Nick, you were going to advise us in terms of next steps, I'm sure.
Thank you, Chair. You know me too well. I was waiting till every member had spoken. Simon, you referred earlier to working with the committee going forward, Chair, and you've already referred back to the recommendations contained within the report. So we would just need to make comments from this committee back to the people who've attended. I think the big question for me, Chair, is to Simon or whoever. Is the committee's involvement. I see, Simon, you've put a comment on chat. It's how this committee is involved going forward and some sort of timescale so we can project plan. I don't know who would like to answer that.
So if I pick up that quickly, Chair, if that's okay, and thanks for that, Nick. Look, we can do some of the detail, I would suggest, outside of formal business in terms of what that looks like over the next 15 months to make sure that we do this in a timely manner. But I think there's two key elements. I think there is absolutely an element of playing the council's role in terms of the council are as much part of the ICS as the NHS is. It's not an either or, it's not an NHS construct. So there's making sure that you're feeding into all other elements of the council conversations around this as it moves through. I think the most formal piece from the scrutiny perspective and the select committee perspective is making sure that you're holding then us to account for the delivery of the integration agenda and we meet the timelines as we move through whatever the primary legislation talks about. So I think there'll be a mix there between the information giving pieces of where's primary legislation up to, what's going on, and then the holding to account for the delivery of the integration agenda in local communities.
And Simon, timelines?
So I think we should plan for what the next 14 months look like, Nick, and work through then what that means in terms of your forward plan with Tracy and with you and with the chair, with Councillor Pert, whether we do that on a 3-monthly basis, whether you want something, whether you want an informal session at some point that's more of a development piece. But I think the formal scrutiny would probably feel like a quarterly basis as we go through this transitional period.
That's great. Thank you, Chair.
Thank you. I think the committee would be keen to be involved in an informal piece, certainly early on, to help in the in putting some of the views and thoughts the committee have shared this morning and making sure they're reflected into what's delivered at the end of the day. I think that's a sensible thing for us to do. Unless I see anyone indicating to the contrary, I'll take that as a suggestion. Obviously, our role isn't to comment on primary legislation if it does go that way. Nor is our role to get in the way of your vote of merger with your primary care network either. So I think what we probably should do from today's report is to thank you for attending. I think that has been really useful to explore lots of areas and what the vision is. And I wonder whether the committee is broadly supportive of the vision and particularly the prevention agenda. And we look forward to working with you as you refine that into what happens on the ground. Is committee happy to go that far this morning?
Agreed.
Okay, thank you.
Agreed.
Thank you. That's really helpful. Thank you, committee. Thank you, NHS colleagues, for really exploring and explaining where you will be looking to go to and where we'll be holding you to account on behalf of our residents for as we go forwards. Thank you.
Thanks, Chair. May some of us be excused now. We'll leave you in Neil Carr's capable hands.
Absolutely, please. I know you've got a busy job to do, all of you. So thank you for your input this morning. Appreciate that. Thank you.
Thank you very much. Bye-bye.
So let us swiftly move on
Item
to
5, Chair.
Item 5 of the agenda. On a day when we are just below 9 million people being vaccinated for the first time and 600,000 vaccinated yesterday, we've invited Neil as the Senior Responsible Officer for the Neil Carr as the Senior Responsible Officer for the vaccination programme alongside his team, Lynn Miller, who I've seen Paddy Hannigan as well, who are the programme director and the clinical director, just to talk about what specifically is happening within Staffordshire. And this session is more about the vaccination programme rather than the vaccines themselves, because without the programme, then frankly, it doesn't land on the ground, which is possibly what we're seeing in other parts of the world, maybe very close to home even. I would encourage members to ask any question they wanted to in terms of local. I wouldn't normally want to try and focus on local issues, but these are important to local people. Neil, do you want to lead out with some opening comments from you and the team?
Thank you very much indeed, Jeremy. Thank you. Colleagues, good morning. I'm very conscious that some councillors through various fora have heard part of this presentation, but you will accept it's fluid. You will accept this is not a sprint. Some would describe it as a marathon. Some would describe it as a relay race. But I think the reality is in Staffordshire, through all partners coming together, I don't have time to pay tribute to all partners, but the response has been nothing short of amazing from all partners. And I thank everyone for that. Can I also, Chairman, thank Lynn Miller and Paddy Hannigan, who have been central to this and really driven us forward. I'd just like to give your committee some headlines, and that is in Staffordshire, to date, we have delivered 177,609 vaccine. First dose, Chairman, that's 165,000, and delivered this week just gone is 58,000 vaccines. We have 56,000 scheduled for this week. And you will know, and Lynn will talk about it, in the cohorts we have to have achieved vaccination or at least offered vaccination by the 14th of February. We have another 115,000 individuals to see. We are well on target. I'm not going to steal any of Lynn's thunder in terms of the model, but it's important to me that councillors do understand it. The only thing I would say before I hand over to Lynn, if I may, data is becoming more and more sophisticated. We are waiting on the NHS to provide the very local data. It is getting better, and I would hope within the next week or so, we'll be in a position to talk at a very local level. All of that said, Chairman, can I pass you on to Lynn Miller? Thank you.
Good morning, Lynn.
Thanks, Councillor, and hello, everybody. Tanisha, could you put the slides up? And as Neil said, I'll try and quickly pull out the highlights and the progress that we've made and the next steps, really, because I know a lot have seen this. But if we could just go by way of an introduction in terms of the background. As you know, we've got 3 licensed vaccines in this country at the moment. Tanisha, if you can move to the next slide. So we're actively using the Pfizer and the AstraZeneca vaccine, and Moderna has been approved also. And Novavax is a new vaccine that's in phase 3 of the trials as well. So you can see lots of pharmaceuticals are developing a very effective vaccine by the sound of it, with some really good rates of effectiveness in the between 75 and 93% effectiveness. So that's fantastic. The vaccines we have at the moment do require double doses, and alongside hand washing, face coverings and social distancing are the way out of the pandemic, as far as I think we're all concerned. If we can move on. Next slide, please, Tanisha. So I think following on from Prem's presentation around the ICS, for me, this is the best example of an integrated care system working. We've worked very, very closely with our local authority colleagues, and under Neil's leadership as part of the programme across Staffordshire, it's very much about a system-wide approach with a league of providers underneath that. Some practical examples of how we've been working with local authority colleagues, using officers' expertise around logistics, traffic management, setting up large-scale sites, certainly that's something that we've really drawn on from the local authorities, but also in terms of reach. Some of the figures that I'll talk about are not just about volumes of people vaccinated, it's about how far we've been able to reach hard to reach groups, and certainly through your communication channels, for your relationships with local authority, care homes, for example. We've really been able to see some very high rates of reach into some of the cohorts that we've been trying to tap into. But just in terms of our approach with our delivery model, we have 4 pillars that underpin our model in Staffordshire. The first pillar is our hospital hubs. These were first to go live at Royal Stoke, but also other sites in St George's. What we're trying to do is stream the cohorts, the populations through the different pillars, so we can keep it nice and clean in terms of trying as best we can make it less confusing so people know where to go, which groups will go where. So the hospital hubs were largely set up to test the vaccine out, but also to vaccinate staff. And as we go through the programme, we're not winding down the hospital hubs, but the activity will be less and focus on the other pillars as we go through. At the moment, our community sites, our PCN sites, we have 23 across Staffordshire, and this is where we're expecting 52% of all of the cohorts to be vaccinated. What we focus on in Staffordshire and Stoke-on-Trent is access. We do have our large-scale sites, which I'll come on to, which definitely have our place, but certainly in the first priority groups, the over 80s, the care homes, the over 70s, we want to make sure that these groups have access to local sites within 10 miles of residency. You can expect to have a PCN site in the community, and certainly again that's how we've been able to achieve such high figures across our over 80s, because these are trusted. They're used to going to doctor surgeries, GP surgeries for the flu vaccine, and the same goes for the COVID vaccine. We are just starting out with our vaccination sites. So last week Tunstall went live, the Daniel Platt Centre. Today, Kingston Centre in Stafford goes live, followed by next week the Uralwas site at Whitemore Lakes. We'll see these come into their own as they see the younger cohorts, if you like. This is where access will be 7 days a week, 8 till 8, so people can manage their vaccine around work. But certainly we've had some really good feedback this week around these sites, and some of our MPs have actually been volunteering in these sites this week, so I hope that was a good experience for them. The fourth pillar is our roving model, focused on making sure that the housebound, the prison population, care homes receive their vaccine, and also those seldom heard groups such as homeless and some more difficult to reach populations, actually, that these we'll have to take the vaccine to them rather than the other way around. So I'll just move on quickly, Tanisha. So I'm sure you're all aware we are working through priority groups 1 to 4 at the moment, and as Neil said, by next 14th of February, in 2 weeks' time, we will have expected to have vaccinated the top 4 priority groups, so the over 70s, over 80s, and care homes and health and care staff. If I was going to estimate where we are, I think we are at least 75% of our over 70s have been vaccinated in Staffordshire. The big proportion we're working through at the moment in terms of volumes are the care home workforce, local authority workforce. But by the end of the week, I'm expecting we'll be 70%, 75% there. We are starting to think about going forward into the remaining tiers, but we won't move into any tier before everybody in the preceding tiers have been vaccinated. So we've been very clear with our PCNs, we have to vaccinate the over 80s groups, and they're not able to go down the tiers until they've vaccinated that group. And they've been very, very compliant with that to make sure that the right people get the right vaccine at the right time. Next slide, please, Tanisha. So our PCN sites, our 23 sites, went in waves. Now this caused some issues amongst some communities, as we know that some sites went before others. It was nationally derived. We had approved all of our sites good to go, but nationally they defined that process. But certainly all of our sites were ready to go around Christmas time. 6 went in wave 1, followed by a further 8, and the 18th of December, and every site is now live in Staffordshire, which is really positive because our model is quite unique, that we have 100% population coverage with our PCNs, which not all areas do. You can see that again, how the gradual phasing in of the hospital sites and the vaccine sites. And just picking up the councillor's point around community pharmacies, we have 5 community pharmacies go live in Staffordshire that complement our model. It's commissioned by NHS England, but what we're trying to do is bring them into the fold. The PCNs, the primary care networks, are a planning footprint for us as well as a delivery footprint. So we want to make sure that we've got the capacity and reach in every area, and they're working in collaboration and not competition, which sometimes our pharmacists and GPs have done in the past. So we can just move on. As I said, this is a gradual rollout. If we can move the next slide, I'm just conscious of time. Our large sort of vaccination centres, I mentioned those centres which are described on the right. These are led by Neil's organisation, by MPFT. Last week at the Daniel Platt Centre, there were 3,500 health and care workforce went through these centres. And over the next 2 weeks, the remaining healthcare workforce will go through Whitemore Lakes and Kingston Centre. And we will see a gradual ramping up in the capacity in these centres as we move through the next priority groups. The large scale centres, and this we'll see the bulk going forward. Now, I think we need to remember it is a marathon, not a sprint. Huge amount of energy has gone into manning the PCN and vaccination sites. So it's very much underpinned by a workforce hub, so we can bring people in sessionally to manage these centres. So our volunteer workforce are really important to that, and we need a continual flow of volunteers to keep these sites open. So fantastic effort to get these sites up and running. And you know, there's a thank you there to local authority colleagues and officers within both local authorities have been leading this programme of work, because that's where we felt the expertise lay. So thank you to that. So just in terms of the progress, next slide. Neil touched on some of the figures. So that figure over the weekend has increased to 177,000 doses. That's how quickly we can get through the numbers. We see in some cases 1,150 patients in a single 6-hour clinic. So over the weekend it has shot up significantly. We've delivered 86%, it's nearly 87% of our over 80s. And I think it's a huge achievement to say that we're the 7th highest STP in the country in terms of the cohort penetration in that group. And that again is down to reach. It's about not leaving anybody behind. And we're on track to deliver by the end of January. We have recognised that there is some variation in terms of uptake amongst different ethnic minority groups, and also amongst some staff groups as well, who we do need to give to have some work around that. We've set up a task and finish group now for hard to reach groups to make sure that our BAME communities receive equal access to the vaccine, and we're going to have to work quite differently to make sure that nobody gets left behind and everybody receives the vaccine who should want it. It says there 99.9% of care homes have been visited by PCNs. 100% of homes have. Where we have some small outbreaks, we've still got some residents to vaccinate, but all of our PCNs have been to all of our homes. And again, we've worked very closely with local authority colleagues to plan this, to make sure we've got relationships with the homes, with the management within their homes, etc. So again, with a very short space of time, we've vaccinated 100% of our homes. It's about 88% of residents. So if last week was care home week, this week's home visiting week. Our PCNs are taking the AZ vaccine, which is a lot easier to port to make sure that those who are defined as housebound also receive their vaccine, for those people who can't come into clinic. There's been quite a bit in the news around waste. I'm pleased to say we've got very little waste in Staffordshire. We've had some issues of people being vaccinated who are outside of cohorts, so police, fire, etc. We've been working really hard with the police and the fire service to ensure that that their staff aren't put in difficult positions. But actually what we're finding is now we have got all of our slots booked up. with the AZ vaccine, there's far little waste, but actually we're seeing very few people decline the vaccine as well. So I think that's something that we've managed really well, and that's why we've been able to achieve such high levels of vaccination in the cohorts. So if we just go to the next slide, and I'll hand over to Paddy for this one.
Thanks, Lynn. People will be aware that the guidance around sort of the second dose changed nationally probably about 3 weeks ago now. This was based on a sort of review of the available research from all 3 trials from the 3 licensed UK vaccines. So the Joint Committee of Vaccination and Immunisation changed the guidance to say that the public health will be better served in this phase by doubling the number of people getting first dose rather than starting to do a lot of second doses. Our hospital hub and some of our PCN sites had started mid-December, so we'd already commenced some of the second doses prior to the change in guidance. We had about a week of sort of handover, and then since then we've done virtually no second doses, and we intend to keep that sort of policy in line with the sort of national policy up until the 12-week mark, when we will obviously start to do all those second doses. For some people, that's going to be fairly quickly after the mid-February target, and so we're already modelling how we'll both cover of the second dose cohorts as they come through, and continue to do the next cohorts down through sort of end of February into March and beyond. As Lynn said, we've done quite a lot of modelling around our capacity and our different elements of the delivery structure, and we think we've still got considerable capacity to go, and we don't envisage that being a problem. Want to go to the next slide? Sorry, I'm just on the last slide, I didn't point out that the number of lives needed to, or the number of vaccinations needed to save 1 life is in the box on the right, and it does make it fairly stark in terms of what we're doing in this phase. The first 4 cohorts, the number of lives saved by the vaccination potentially will be considerable, particularly in care homes. For every 20 vaccines we give, we potentially prevent one person dying of COVID. In the over 80s, 160, and down to sort of 1 in 600 for the over 70s. As you start to go down beyond that, the numbers start to go up very quickly. So in the sort of above 50 age group, the figures are looking at 1 in sort of 4,000 to 8,000, and below 50. If you don't have any other health conditions, the number of people vaccinated to prevent 1 death goes up to something like 1 in 47,000. So in terms of saving lives, this initial phase up to mid-February is where most of that impact will happen. Go to the next slide. Lynn, I don't know if you want to pick this up, or you're happy for me to carry on.
I'm happy, Paddy, if you want to carry on.
Yeah. So how do you get an appointment? As Lynn said, 52% of our patients will probably go through their GP PCN sites. Those people at the moment are being phoned, text message, and some will get letters from their GPs, but predominantly it's done on the phone. Sometimes the lead-in time between knowing when the vaccine's arriving in the clinic is fairly short. And again, the power of persuasion on the phone is very effective. Having said that, it doesn't take much persuasion to get somebody in the first 4 cohorts in for their vaccination. We're getting reports from some of our sites that the refusal rate to date has been something like 2 or 3%. So really low refusal rates in the current age groups. We've got some issues around contacting some people, and as I say, we just work away at different ways of getting in contact with them. The vaccination centres and the pharmacies are running on what's called the national booking system. People will be getting letters. The over 80 letters already gone out. There's a second wave of letters went out at the end of last week for the over 70s. These letters invite people to phone in or contact the National Booking Centre, and they can access appointments at the vaccination centres and their pharmacies. It currently doesn't allow them to book into their GP sites. There is an issue around people potentially getting more than one offer for an appointment, either the national letter or from their GP. We're not getting much evidence that that's causing people to double book. We are getting a little bit of feedback, particularly from the GPs, that they're phoning people up and if they've already got an appointment booked somewhere else. So it creates a little bit of noise. Hopefully in time we'll see a system that's probably a little bit more joined up. There's a bit of concern about, if I miss my phone call, will I get called again? And the answer is yes. I mean, although we've got this mid-February target for these first four cohorts, we're working very closely, particularly with the GP sites, to look at their percentage uptake in each of these cohorts, and that basically is a request to GPs to keep trying and keep making contact with people who so far haven't taken up appointments. So we will continue to offer, and we will continue to offer past the mid-February target date for these cohorts. The offer won't end, it will be continuous, and as ever we will take any opportunity if people are making contact for any reason. If they haven't already had the jab, we will be offering it at any opportunistic occasion. We'll continue to do that. Next slide. We are being fairly clear that in our messaging that having the vaccine does not allow you to return to normal life. Everybody who's given a vaccine is given a takeaway leaflet at the end of their after their vaccine's been given. Especially with Pfizer, you've got 15 minutes to kill under observation, and most GPs are taking the opportunity to persuade people to read their leaflet whilst they're waiting, and actually using things like TV screens to reinforce messages around washing hands, covering your face, keep your distance, as everybody has been saying. So we're very clear in our messaging, both through our wider comms, but the post-vaccination literature. As I say, I was doing the session at County Showground yesterday. Everybody's given a little ticket to wait 15 minutes, and at the bottom of that is stamped the same message: wash your hands, cover your face, keep your distance, and don't assume that just because you've had your first dose that you are can drop your guard. Next slide. I think that brings us to an end.
Thank you, Paddy. So I just want to raise two things and then just bring in Kath Perry, because I know that Kath is on a hard and fast. So we've seen the slides have come. I'm assuming there is nothing secret in the slides. And on the same basis, it seemed rather bizarre that the vaccination centres were being kept secret or not necessarily publicly aware, given that actually people have been invited to them since the beginning of December. Is that position now sort of has that now been changed, and have we taken a more pragmatic approach? Let me bring in Kath to ask her question, and then if we can take them in groups, we'll hopefully get through everybody. Kath.
Thank you very much, Chairman, for allowing me to come in early. Unfortunately, it's a funeral I've got to go to, and he was a COVID. It's a very good friend, so anyway, that's another story. What I'd like to say is thank you very much indeed to Neil and to Lynn and to Paddy for getting this. It's excellent. I'm only hearing good reports, if I'll be quite honest with you. So thank you very much, and thank your colleagues also. We've got an excellent one going now in Great Worley, run through the pharmacy. I volunteer myself as a volunteer, and we've got 80 plus volunteers. I just wanted to make these comments to say how pleasing it is to see the recipients when they have had their injection. The relief on their faces is absolutely, well, you can't describe it. It's so heartwarming. They cry, some of them do, if I'll be quite honest with you. They're so emotional. So I'm pleased that it seems to be going well. Obviously, the GP surgeries are also doing their vaccinations as well, as and when they can. And it's just pleasing to see how well Staffordshire are doing through yourselves in rolling out the vaccine. So thank you very much indeed. I just wanted to make those comments. Thank you.
Thank you. Do you want to pick up any comments from that, Neil, Lynn, Paddy?
If I may, Jeremy, I was at the vaccination centre in Tunstall, the Daniel Platt Centre, on Saturday, and there were a couple of nurses there that normally work in intensive care. And I was saying to them, I thought you would have wanted some time off to rest, given what you're experiencing. What they actually said to me took the winds out of my sail. Seeing the people, seeing the smile, getting that camaraderie, that the basics, it's a shot in my arm, and I do it because it gives me the strength to continue on in the intensive care unit. So we've got people have come forward from all aspects of health and social care. But what I want to say is not only are citizens, I think, relieved to get the vaccine, but staff are finding this very reinforcing and very rewarding. And I think it's important we understand that. It really has lifted morale.
Thank you. And in terms of the secrecy of the slides or the vaccination centres?
Jeremy, I apologise for that. I would like to be very pragmatic. It's out in the open, and I regret it had to be kept a secret.
So are they now available, sort of public domain? Is that now the place where we are?
Yes.
Thank you. And the slides, you're happy for them to be shared more widely across colleagues and communities?
Yes.
Thank you. Let's just take two questions next. Charlotte and Anne, we've got quite a few people questioning, so if we can be brief, please.
Yes, just quickly to say, well, it's great to see that the care homes have been reached. I'm hoping that that means that the care staff have also been vaccinated, that we haven't had people not wanting to do that. But my only concern is that some areas have been penalised for their success, in the sense that vaccinations have been, vaccine has been held back by government in certain areas. And I'm just a bit worried about that. And the only other thing I wanted to ask about was the gap between the first vaccine and the second one. I believe the BMA have said it should be 6 weeks, whereas in fact I think from your side you're working to a 12-week base. And I wondered whether what's being said about that gap between the first and the second vaccine. Thank you.
Yeah. If I can, Councillor Atkins, I'll ask Paddy to comment in a second, in particular about some of the care workers who are potentially reluctant to have the vaccine. But can I say, we have not received any notification. In fact, I think Lynn can confirm, we now know that our vaccine continues to flow, and we can probably plan better than we've ever been able to plan. And our numbers remain quite high for the next couple of weeks, allowing us certainly to hit our first 4 cohorts, we believe, comfortably. But Paddy, can I ask you to pick some of the issues up about BMA and some of the young women working in care homes?
Yeah, the change to the 12-week scheduling is a science-based argument, and it's based on a reasonably British pragmatic view of all of the data that's available from all 3 studies. And rather than just looking at each study narrowly, what they've done is they've taken all of the evidence and they've done a little bit of extrapolation between the studies. And equally, they've taken a public health view is what is going to have the potentially the highest impact on preventing deaths in this cohort. And so the Joint Committee of Vaccination and Immunisation, JCVI, and all of the Royal Colleges have unanimously come out in favour of the UK 12-week strategy. I think if we had unlimited vaccine and unlimited capacity, I don't think we'd be doing this. But because we don't have unlimited capacity, and we certainly don't at the moment have unlimited vaccine, I think if you're going to try and do the greatest good, you have to give twice as many people 1 dose. And particularly if you look at the hospitalization rates and the death rates after 10 to 14 days when the vaccine is active, that's how they've got to this sort of reasonably high level of confidence that the vaccines are effective. And on that basis, a single dose seems to offer quite high protection, and therefore giving it to twice as many people makes the greatest impact on deaths most quickly. The BMA have come out with a different position. I think they've looked at it very narrowly. They haven't looked at the public health perspective. They haven't looked at the pragmatics of, a still slightly constrained vaccine supply. I think their view hasn't gained much traction even in my colleagues, and it certainly hasn't gained much traction with the rest of the medical establishment. So we're following JCVI, and unless that changes, we're going to continue with the 12-dose strategy. The anecdotal messaging around younger people, and I know it's first surfaced in care homes, but I think it's actually sort of more wide than just care home staff. I think it's like a lot of the stuff we're seeing on social media, that there's no medical evidence that the vaccine has any effect on fertility, and whilst it still carries the same warnings that any new vaccine will have to carry about pregnancy, i.e. we haven't done any research in pregnant women, and therefore we can't currently recommend it unless they're at serious health risk. I think that there is no evidence, and so what we've got to now do is just try and get that through our comms messages and be fairly clear about that. I think our other issue about the care homes is counting the care home uptake is slightly tricky, because we've actually been pushing our care home staff through multiple routes, the visits to care homes by GPs, but we've also used our hospital hubs, our PCN sites. And in fact, we've been routing them through all of our available resource, but it's difficult to count them through some of those, and a lot of our care home staff may actually come into some of our other categories in any case. So I think the numbers in care homes, I hope, are much higher than the national figures suggest. And I think the problem may be smaller than we're thinking, but we're still obviously trying to get all care staff vaccinated as quickly as possible.
Thank you.
Thank you. Thank you.
Chairman, if I may, could Lynn just come in very briefly around communication and the BAME community? And I know Tracy Shewin is on this call because it's an issue we need to get closer to. Lynn, please.
Yeah, thanks, Neil. I mean, I think I said in the presentation that while volume is important, reach is equally important. We don't want anybody to get left behind due to deprivation, demographics, or their ethnicity. And some startling figures have come out across the region, actually, that there is a disparity between Afro-Caribbeans, Bangladeshi population. So we've started to do some of that work in Staffordshire, and certainly it is emphasised with deprivation. That makes it even more stark. So we've set up a task and finish group. We have a clinical lead who's coming to our programme board on Thursday to present the size of the issue or not, because we've got high uptake, but we've still got a small proportion who are not accessing the vaccine. And we'll pull together a plan working with all of our colleagues in the local authority, with our comms team, to be able to make sure that we reduce any inequity that there is. And already Tracy and some of our clinical leads have met with faith leaders. We've got communication, but we really want to make sure that we've got everybody involved with helping us to vaccinate as many people as possible. So that work will be ongoing, and it's an absolute core part of the programme structure that we've put in place.
Thank you, Lynn. Really helpful. Clearly, there's a role for all of us in encouraging everyone to take up the vaccine. Equally, I think that we as the local authority demonstrated with the track and trace that a local approach with local community grounding helps. And I would encourage you to keep that active dialogue going with the local outbreak control board, which is representatives from everyone within the district and borough councils and county council. And Angela.
Thank you very much, Chairman. Good morning, everyone. I just want to say what a fantastic job that you're doing, and that's not just my words, that is the words of the general public. All the good work, and the things I'm picking up, everybody is praising the way it's been put together, so thank you for that. And I also just want to mention that I had my first appointment last week. I've got my second appointment booked in April, so hopefully that will, and it also came along with 17 different languages as well, which I thought was very, very good. But my two questions I've got for you, and these, we've talked about carers and we've talked about care staff, but can I ask, what about the unpaid carers? What about the people that's looking after people at home? because they're housebound and they're caring for that person, but they're missing out on actually being vaccinated. So that's one issue I want to pick up. It's been highlighted to me in the last week. And the other thing is, I'm picking up now, I've got a lady, she's 103, she's housebound, she's got carers going in at home who have not been vaccinated. She's not had her vaccination. I actually got involved personally and I rang the doctor's surgery. I know I shouldn't, but I did because I was concerned about this lady, and I was told it was the district nurses that were doing it. I spoke to the district nurses and they tell me, no, they're not doing it. Because she doesn't actually, although she's in a Colwich surgery, she comes under Stafford, not under Rugeley. So this lady is missing out on her vaccination, and it really concerns me. So I think we as council have got a part. I know we shouldn't get involved, but when we've got family's permission, then we do get involved and to help get these 3 people through the net. So if you could answer those 2 questions for me, I'll be very grateful. Thank you.
Sure.
Lynn, are they ones for you? Oh, sorry.
Sorry, can I pick those up very briefly, Jeremy?
Please.
And I think we're having a lot of correspondence from individuals who are unpaid carers. If they don't fall into one of those 4 categories at the moment, then I'm afraid to say we're having to be very blunt, and they're not eligible. And that's difficult, but we are having to distinguish between paid and unpaid in terms of the 4 categories. I think the other thing to say is, if we have people now over the age of 80 who have not been vaccinated, then one of the things we should be doing is flagging that. I don't want floodgates to open to GP surgeries, etc. But if we have someone who would be in that absolute top priority, 100 and odd, still hasn't received, then I think it's right and proper that we do contact the surgery. Can I say, and I don't know the individual circumstances, but we've agreed when GPs need assistance or support with the housebound, that district nurses will. So there may be some debate as to which district nurse, but the principle is well established. But if you let me have the details, I'll follow that up. That lady deserves a vaccine.
Thank you, Neil. Thank you for that.
Absolutely agree, Neil. And presumably you would encourage people to point people towards the FAQs on your website in terms of some of the detailed answers to some of the questions that people might quite rightly have.
Yes, and we've tried to update those, Jeremy, as we go. It's difficult, but that is that's our position.
And could you also just circulate an email address that we can raise any concerns that we've got to you? Because I'm sure, Neil, with everything you've got on your plate, you don't want, a small number of emails about 103-year-olds, as much as I'm sure that you care about that sort of level of detail and making sure no one's left behind. But if you can give us an email address we can circulate to committee, I'd be grateful, please.
And we can do that after this meeting, certainly.
Can I come back, Chairman, just to say
very briefly.
Yeah, I'm really concerned about these unpaid carers, and I don't know the answer to it, but I'm really concerned because they're looking after vulnerable people. Thank you.
I'm sure Paddy would answer that it's related to the JCVI.
I think Lynn's trying to come in, so I'll
just very quickly, Councillor, and by way of elimination, I know which practice you're talking about, so I'm sure Paddy and I can pick that one up. But in terms of unpaid carers, what we are going through a process with the local authority is identifying everybody who is eligible. So if they're working with a personal health budget as a carer, or if they're actually part of any voluntary organisation, we're working very closely with them to identify eligibility. So if there are organisations or individuals that the councillors think are eligible, then we need to know we can make that assessment.
Just on the JCVI thing, I mean, as Neil said, we're going at the moment on the highest levels of individual risk, and we've got to be quite careful given capacity and vaccine supply that we use our vaccine to its greatest effect. I think if we have a very broad interpretation of carer, I think that will eat into our capacity to do people who are at individually much higher risk. And particularly anybody who is travelling from across multiple different patients or citizens providing care, as Lynn's described, absolutely we would do that because of the sort of multiplying risk. but some of these one-to-one caring roles, probably the carer is actually personally often quite low risk compared to the first 4 categories. So we need to just be careful as how we deploy the first phase.
Thank you. Jill, can I bring you in, please?
Thank you, Chairman. I've got 3 points. I volunteer almost every day taking residents to the county showground and yesterday to Burslem. And what I can't understand is the fact that I'm taking married couples, and when we get there, there's only one of them being vaccinated, even though they're in the same age bracket. This seems a real breakdown in communication. The second point is that I know most of the volunteers at the county showground, and it is being said to me there are people who are not turning up and we're having vaccines thrown away. I know, Lynn, you said that it wasn't a huge problem, but surely we could have some kind of reservist list whereby in the morning, when we realise we've got 2 or 3 people not turned up, we could contact someone, or even in the evening. The second one really is a bit of humour that my clients, my people who I volunteer for, are over the moon with the service that they're getting. It's you know, the gratitude that they're showing is overwhelming. And I know someone talked about crying, but I actually sat and cried one day. It's incredible. But I had an elderly gentleman, very old, who complained all the way home about how slow it had taken. But it transpired that talking to one of the volunteers, he had a coat, a scarf, a jacket, a cardigan, a shirt, a vest, and then some other contraption. And it literally had taken 20 minutes to peel off this gentleman's coat. But I just must extend my thanks. But I would be grateful for an answer just to my 2 first serious points.
Perhaps take that. I absolutely agree. I mean, if you've got a couple attending for vaccination, you would really want to try and do both in the same appointment. I mean, our issue to date has been, again, probably driven by vaccine supply. So with the Pfizer vaccine, you know, until fairly recently, the sites, or particularly the showground site where I've done sessions, would often get, you know, 24, 48 hours notice of confirmation and have to book people in fairly furiously. Also because of the limitation, it has been a bit of a race for the practices to try and take those slots. So I mean, literally, you can see them disappear in front of your eyes. So, you know, trying to get 2 people into side-by-side slots has been difficult. Some of that's going away because the amount of vaccine has doubled in the last 2 weeks. So we, you know, 3 weeks ago we had about 24,000 vaccines. Then we had 44, and as we just described, it was 55 sort of last 2 weeks. So it's a lot of those issues are getting better, but absolutely we try and be pragmatic. So if we're going in to do a housebound visit and there's another person in the house, we will try and do both. But the speed of this is, I've never seen anything like it in terms of the speed and the volume. So we are getting anomalies in terms of things that you would otherwise not want to do if you had a bit more planning. The reserve list thing. Again, I've done 5 vaccination sessions. I mean, it's especially with the Pfizer vaccine, we've got 3.5 days to use it. I mean, people take it really personally if there's any vaccine wasted in a session. And yesterday at the end of our session, we went down to the last dose in the vial, and we got it used. So we're getting fairly good at knowing how many doses we've got. So we know a pallet of Pfizer nominally has 975 doses. We know we can take a 6th dose. We're now reasonably confident that we can do that. Not 100% of the time, but most of the time. So we'll book, 1,150, 1,160 patients in. We do have reserve lists. We try and keep the reserve lists, again, first 4 cohorts. But as we get down to the last few doses, it will be people doing the vaccinations, volunteers, but we will make sure that vaccine gets used. But we do try and we are getting better at making sure that it's targeted at those first 4 categories. But very little waste. I mean, I hardly see any waste at the moment.
Thank you, Paddy.
Thank you, Jill. Bernard.
Thank you, Chair. I just perhaps going back to Lynn Miller's point about hard to reach groups and trying to get to as many people as possible. And I do hope that this isn't a particularly sensitive point, but in East Staffordshire, I am hearing reports that perhaps some of the Muslim community are reluctant to have the vaccination because of what their perception and belief is as to the constituent parts. Now, I'm not medically qualified, so I can't offer a comment on that, but is there anything in that story? And if there is, you know, what sort of challenge is it presenting to you?
Paddy?
Yes and no is the answer. So from a scientific point of view, no, there is no component of the vaccines that should cause any of our communities and any specific problems. And there've been fairly clear statements, particularly from through the sort of Muslim organisations and some of the other religious organisations where we've had sort of at national level and at local level fairly clear statements to say this product does not contain anything that should cause you any concern. So those statements have been made, but the trouble is you're always against social media. So in reality, the yes bit is it is an issue. I mean, we're now getting some statistics through about uptake levels across different sort of ethnic groups, and you can see it fall off in just the way you might imagine. So having seen that, and actually we know this from our flu vaccination campaigns, you know, and we've already done work in the autumn around getting our flu uptakes high. So we are just mobilising all of those approaches again, and we will look at a whole range of different approaches as to how we can reach these communities, whether it's trying to correct the message, whether it's trying to get local faith leaders and recognisably local leaders to do videos and make statements, whether it's pop-up vaccination clinics in religious buildings or churches or wherever. There's a whole variety of techniques that we can do, and we have done before, and we will try and push the rates up. The sort of level of data we've got through since last week is getting better and more detailed, particularly at sort of site levels or even down to GP practice level, and that will allow us to tailor some of our different approaches in a much more refined way.
Bernard, do you want to come back on what you've heard?
Thank you for that, Paddy. It's fairly reassuring. I would just ask you if, let me not be controversial, but are you proceeding at pace on this? I don't get a sense of pace. I heard what you said, but the message is the drumbeat message continues in East Staffordshire. So I can see Neil nodding his head, but yeah. I'll take that as a yes then. But there is a need to make sure this message gets home. And I know the local authority in East Staffordshire are working very hard to support the particular groups I'm talking about.
Yeah, absolutely. And thank you, Councillor Peters. I can confirm that we are targeting certain groups through people like Baz Kaur, one of our community relations officers, one of the GPs, Dr. Shami Noor, etc. And because this is a concern to us and a national concern, we've now established another subgroup, as Lynn said, of our board. And we will be targeting specific areas based on different need, because within communities, there are often different groups who have different needs, a different focus. So we're trying to do it with local communities as opposed to pretending one size fits all. But I know Tracy Shewin's on the call, our Director of Comms, and I know she's been very active in this. So I'm not looking to put you on the spot, Tracy, but by way of reassurance, is there anything you can talk about in terms of pace?
Yeah, absolutely. And we're also looking at community champions as well to tackle all the issues that we've brought forward. And like you said, the meetings have already taken place with faith leaders. We've worked really well with local authority, district and borough councils, especially over the testing programme, especially in East Staffordshire. So we've learnt lessons from there, so we can actually move at pace to make sure we are squashing some of the rumours that have been sort of around, and certainly social media playing its part and what we can do on social media. But what really is, it's a call to everybody, and that's what we will be doing, is making sure, and well, we are doing, is making sure that we get the messages out to the right people. And like you say, look, are we doing our vaccinations in the right place? You know, are we accessible? What are the issues that we need to do? Is it just the noise on the vaccine about what the products are, or is it something else? So we're really getting into the sort of nitty gritty, and yes, moving at pace on that.
Thank you, Chair.
And obviously worth mentioning, Tracy, that some of your work ties into the other local resilience forum partners to make sure the message is being shared as widely as possible across all communities, so that it's heard not just through one source but multiple sources. And obviously you would be keen for other people to pass that on as well.
That would be really helpful. Thank you, Chair.
Thank you. Bernard, does that help in terms of giving some reassurance? I think there's work to be done, but let's keep close to it.
Yes, I'm obliged and grateful for the clarity around those comments. Thank you.
Phil Hewitt, good morning.
Good morning. How are we all? In the interest of time, can I just firstly echo everybody said what a great job you're doing, Paddy and Neil, etc. It's pretty impressive, and sort of it is impressive. My question is really to Paddy, and it's about the double running, Paddy, when people are getting the second vaccine, and I guess the over 65s will be sort of starting to appear there, and the ability to double run and do them both. You did actually say that was okay, and you could do that. Is it possible to have a little bit more detail on that, Paddy?
I'm going to pass you back to Lynn, who's probably the best person to talk about our capacity and modelling.
Is it possible to have a little more detail on that then, Lynn?
Yes, of course, Councillor. So obviously we're trying to think ahead now in terms of the next cohorts. What we've done is some capacity demand modelling that shows when we'll need to start our second doses and when we're expected to start our first doses in that under 70s bracket. We've tested our capacity with PCNs and the vaccine centres, and the beauty of our model is that we can flex our capacity quite quickly. It's very responsive delivery model that we've got. So currently PCNs alone are doing around 50,000 vaccines this week. Our vaccination centres are around 12,000 next week. But we can increase that quite quickly to respond to the demand. So our PCNs have got capacity for around 90,000 if we really pushed it. And again, our vaccination centres can deliver 40,000 a week. So I think we've got enough capacity in the system to be able to double run. And we also know that our different pillars will come online at different times. So as our GPs, private care networks are doing the second doses, we're expecting that the vaccination centres will come into their own and start working down their cohorts. So we'll have this ebb and flow between the pillars to be able to manage the capacity appropriately. But it is a real logistical plan that we have to do to make sure the vaccine goes to the right place at the right time for the right cohort. But we have got enough capacity to do that, and we're planning for it, Councillor.
Jeremy, if you'll indulge me just for 30 seconds, and Lynn can correct me. We have a number of, we call them pods inside the big vaccination centres, but in reality, vaccine not being a problem, we could very easily with 2 pods see over 1,000 patients a day, as Lynn has said. Now, what we're quite keen is people who've had their first vaccine go back to the same place to have their second vaccine. So for a period of time, that's likely to preoccupy general practice and the PCMs. But the beauty is when we're driving into the mass population, the hubs, the 3 vaccination centres could very easily double their capacity and could easily see between 10 and 14,000 people a week. So if you just look and multiply that, if we're working effectively, we can allow the existing place that gave the first to give the second, and we can up the capacity of the first doses. And the beauty of it is, at the moment, we have sufficient staff who are able to do that. And we have about 250 volunteers who are prepared to help us. So at the moment, we're in quite a good place. And as Lynn says, we can flex very easily.
Thank you, Neil. Phil.
Chairman, that was a great answer, and it comforts me. He just, I was comforted before, but he just felt it. He said, "Oh, that was going to be okay," and I just wanted a little bit more detail. We should have done that. And then just one more point on which I don't record an answer. He's just going back to Bernard's point, and I'm sure I echo a number of councillors and other people on this thing. I get more and more concerned about the level of untruths that appear on social media that create these mass problems, that create some of these problems, and that's just a personal concern that I have, and I felt the need to echo that. So thank you for indulging me there, Chairman.
Thank you, Phil. And obviously, as community leaders, we've all got roles to play to try and do something to support the NHS in turning around those rumours to make sure that they're shown for what they are. But thank you.
Chairman. We absolutely have, yes.
Yeah, appreciate that. Paul Northcote.
Thank you, Chairman. Just briefly, and I know Lynn and Neil, you've partly answered this, but is there a planned intervention to revisit those that are refusing vaccinations? Because obviously we need to incorporate every single person, but I just wondered if there's a planned process in place, and if there is, when that's going to be looked at, or if it isn't, when that's going to be in place to primarily look at those that have refused. Thank you.
Thank you. The bottom line is that is part of our plan, Councillor Northcote. We will know who those individuals are. As Dr. Hannigan suggested, we will keep chasing, but at the end of the day, we cannot demand or insist. But yes, there will be a recall procedure.
Thank you for that. And obviously, as councillors, we have that duty to inform residents and constituents to the advantages of having the vaccine as much as possible. So thank you for that.
Thank you, Paul. Sorry, Paddy.
Yeah, I'm just going to add the refusal rate in the sort of first four population is really small. So I quoted about 2% in the over 80s, so it's tiny. I think the refusal is going to become a problem as we get further down and into the younger age group. So I think it's not. It might be an issue for sort of some of the workforce groups, as we discussed earlier, but certainly in the people where we want the most impact in this phase, that's not the issue. I think the issues around the harder to reach communities, our rural populations, I think, is an issue. I think that sort of reach that Lynn's described, that we've got through general practice will hopefully lead to really high uptake levels. And we've had some of the PCNs getting sort of uptake levels in the over 80 group of in the mid to high 90s. That's better than any other vaccination that we do. I mean, the best of the children's vaccines are mid to high 90s, so it's really unusual to see that, and we certainly never been anywhere near that in terms of flu vaccination programs. So the uptake in these four groups looks like it's going to be way better than we would ever get for flu. I think a lot of the concerns we have are probably going to be for later. And I suspect that there will be other pressures that will be brought to bear on that. I can imagine that you're not going to be going to Spain until you've got a vaccine certificate in the future, and that's going to be more powerful than anything you or I can say.
Thank you. Paul, do you want to come back on any of that, or shall I go on to David Latham? David, the floor is yours.
Thank you, Chairman. I'm 72 and I've had my letter or email from the doctor's practice to go to the cathedral in Lichfield on Wednesday for my vaccination. My wife is clinically extremely vulnerable and hasn't heard anything yet. I'm really anxious that she, who needs the vaccination more than me really, does get the vaccination. Is there any point in me taking her with me in the hope that she could be vaccinated as well as me on Wednesday? I think the answer is no, but I'd seek clarification, please.
Do you want me to pick that one up, Neil? So the JCVI does define, have a definition of clinically extremely vulnerable, and we know how many residents of Staffordshire fall into that bracket. So they are classed as more hard to reach in terms of some of these are shielding at home. So as we go through the housebound process, It may be that most will be picked up through that route. Most practices know who they are and will be contacting them directly. In terms of the particular issue, it depends what your wife's condition is, and I wouldn't want you to discuss that now. But if it is that she does fall into that bracket, it may be that you do speak to your practice about them coming along, and if there is a reserve list, that she joins that reserve list. But obviously it would depend on whether she's fits the criteria, and Paddy might want to expand on that.
I would just say speak to your practice, because as I said earlier, we will try and book as much capacity as we can for the sites. We're getting very few people not attending, and we're getting a few people in every session who we have to, for medical reasons, turn away. I turned away 2 people yesterday. So there's always a little bit of flexibility, but it tends to be pretty small. But you know, I think, you know, if you speak with your practice, that's the best route to trying to get them to negotiate that. We are trying to do people together. It makes sense, and you know, but I wouldn't just go down on spec, because when you're in these buildings, even with social distancing and everything else, she would be exposing herself to contact, which would be unsafe. But I would see if I could negotiate that with the site or the practice.
Jeremy, may I just reinforce what Paddy said for your constituents? Because the reality is, if our system is working properly, when you arrive, if your name is not on the list, politely I hope, but nevertheless, you will be refused entry to the vaccination centre. So I think, Councillor Latham, please ring the practice, see what's possible, get your wife's name on the list. But I think it's important that we have had people see vaccination centre and have turned up, not in huge numbers, but they have been turned away. So you've either got an appointment or you haven't. And that's one of the ways we can help to maintain social distancing during the process. Thank you.
David, is there anything you want to come back on?
No, fine. That's very clear advice, and I'm grateful. Thank you.
And obviously advice that we can share to other people who may be in the same situation. And I hope that that gets sorted for you, David, positively. Thank you. So whilst there aren't anyone else showing at the moment, Janet, I'm going to get in before you, unfortunately. I just encourage people, if you've got a question, then just show now. I've got 2 questions, please. What is your advice on the flu vaccination, bearing in mind there are some people who have been added into new categories that weren't there last year? Not speaking from personal situation. What is your advice in terms of whether that we should take that up? And second of all, is there more that could be done? I heard what Paddy said about trying to give over some messages to the people who have been vaccinated that we still need to be vigilant. Is there more that could be done just to try and get that message home? Because obviously the vaccine is the only way out of the pandemic. And the last thing we want to do is find that all of the good work and endeavours of everybody across communities, across the NHS, across social care, across all those places is jeopardised. Thank you.
Yeah. Can I ask Dr. Hannigan to answer the first one, and maybe Liv? But I know through our comms, Jeremy, we're also doing a lot about the vaccine is not the answer to all of the ills. It's not the magic bullet. So maybe Lynn and Tracy could pick the second point up.
The flu vaccine, we are getting to the sort of tail end of this year's flu vaccination programme. We've had the best outturn that I've seen in my career this year. I mean, all of the Staffordshire CCGs have been around the 80% mark. I think we've gone from sort of high 79s through to about 82 and a bit percent, which is probably 10 percentage points higher for the over 65s than we've ever seen before. The Times today carried an article saying that flu just hasn't happened this year. 95% reduction in reported flu outbreaks, whether it's the vaccination or social distancing or both. But a bit like the Australians in their flu season in our summer, they just didn't see a flu outbreak this year. We haven't either. We are still offering flu vaccination, and the combination of influenza plus COVID carries a 2 to 3 times mortality. So we've been very clear about the messaging, and people can still get their flu vaccination. However, we are at the tail end of the programme. I don't expect to see a significant shift in vaccination rates in the sort of remaining few weeks. But the message is out there. There is a bit of noise about you can't have the two things together, or you have to have a 7-day gap between the two vaccines, which is true, but not from any harm point of view. It's just so that if we give concurrent vaccinations and somebody has a side effect, we can't attribute to one or other vaccine. So there's no harm in having them together. It's just that it complicates the sort of interpretation of problems. So, we would at the moment be pushing the COVID vaccine first for much greater risk reduction. I think that's probably all I can say about flu, but it's been a very good year.
Chair, do you want me to pick up on the encouragement of people actually post-vaccination to follow the rules and the Do It For campaign that we've worked with all our partners, local authority, police, fire. We keep reiterating, as part of our response to COVID and coronavirus, that we do still need to do this. Until science tells us something different, we really do have to follow all the guidance, and I would appreciate any of the committee's help in that. And we do send out to all of the boroughs, districts, local authority, because we work with your communications, a pack which has got social media in there. It's got videos, it's got different people actually saying, this is what you should do and this is why you should do it, and you should do it because I want to see my grandchildren, etc. So there's quite a lot out there. So any help in that then would be gratefully received.
Thank you, Tracy. Can I bring in Janet Eagland, please?
Thank you very much, Chairman. I've listened this morning and I'll have to congratulate you all, Neil and your team, for what you're doing. It's very progressive. I'm very happy with what's happening. But while I've been listening to the meeting this morning, I've had a telephone call from a lady in one of my divisions, and she is very anxious because she's had her first vaccination and she's overwhelmed and very pleased about it, but she wants to know why she didn't get a date for her second one. I'm afraid I'm going to come across this problem, and maybe my colleagues will as well. My friend's got her second date, but I haven't. So I'd like some clarification on why some people are getting a second date, and indeed me, I haven't got mine either, but there we are. So perhaps we could have some clarification from one of your team, please, Neil.
Thank you.
On what the answers are. Thank you very much. And Lynn, congratulations once again on what you're doing.
Thanks, Janet. Thank you. Lynn, can I put you on the spot?
Yes, of course, Neil. No, I appreciate that. In some areas, some people are getting a second date and others not. I think to date, we've been determined by the vaccine supply. We're seeing a lot more of a steady flow now, and we should be able to plan for that second date when we start getting a clear vaccine supply. But at the moment, we don't know what day vaccines are arriving. Our primary care colleagues can't order, they can't pull down deliveries. It's a push process, so they get given a delivery on the day that it arrives. So it's really difficult to plan. But certainly that's something that we want to do, to be able to give people that surety around the second dose. So as we get more clarity around the vaccine supply, we will be able to do that. We know that some pharmacies are giving second doses. So I think at the moment we're probably going to have to live with that discrepancy, but everybody will get the second dose. But I do understand it's causing some anxiety for people.
Janet, do you want to come back?
No, that's fine. That's the answer I need to pass on. Okay. So thank you. Just make sure we get your presentation, please, Lynn.
It's already in your inbox, I think.
Thank you very much indeed. Well done.
So, Nick, have you got something you want to raise, or I will look to bring this session to a close?
Just two things. I'm very aware of the time, Chair. So just referring back to the report recommendations.
I've got that in hand, yes.
Yep. The final thing, which I know you and I have spoken about, Chair, is about...
Got that in hand as well?
Right, in that case, I'll leave it to you, Chair.
That's fine, thank you. So let me pick up those 2 points. The first one being the purpose of today's scrutiny session was to make sure that we looked at scrutinising the vaccination programme across Staffordshire as a pan-Staffordshire issue. Most definitely is a Healthy Staffordshire Select Committee issue rather than a locally based issue in all the districts and boroughs. And I'm sure that Lynn, Paddy and Neil would appreciate not being invited to attend 9 meetings when there is one which we've just done. So I think if anyone's got any questions that come out of today's meeting or that residents raise, quite rightly so, I would point them certainly towards the FAQs on the website, but also Neil would give us an email address so that we can ensure there is an ongoing dialogue. And then the third way is through the local outbreak control board, where you have representatives and nominees at a senior level who are representing your districts and boroughs. I hope that makes sense. If you want to pick up any questions on that, happy to do so later. Secondly, I just wanted to say some closing comments first, which is sorry, I should have also mentioned there's a twice weekly communication pack that Neil and the team, Neil and Paddy, author and send out to all councillors. So if there's anyone on this meeting today who is not seeing those, please can I ask that you drop Nick a note, Nick Poltney a note, just so that we can ensure that you're added to those, and those can be circulated to other councillors just so that it gives an up-to-date position as to the military position of Lynn's operation, Paddy's operation and Neil's operation, because I think that as many members have said today, it is impressive. There is also a plan to do a further webinar which will pick up some of the more local points about trying to encourage everyone in the community to act as sponsors for getting everyone vaccinated. So, closing comments. I like your reassurance today that everyone in the top 4 categories will get picked up by the middle of February, and that no one resident within Staffordshire is going to get left behind. Thank you. I appreciate that work to make sure that we do make sure no one's left behind, particularly the most vulnerable. I also pick up your ask of us as a committee, which is to volunteer if we can at some of the vaccination centres, to provide community transport if that's what's needed to make sure that people can get to those places, and to be role models and to continue to positively get people to take the vaccine if they can. Sorry, when they're offered it, not if they can, when they're offered it. The report asks us to consider the information provided and to comment on it and to look at the next steps. I think everyone universally has talked about the military precision and the positive feel that is universally felt by those people who have had vaccines. I certainly would like to add my voice of thanks to everything that Lynn, Paddy and Neil, you are doing as a team and right the way through your organisation. It is very unusual to find everybody is universally thankful for the work that has gone on and the way that it is being run. I understand some of the difficulties of that, so thank you. And we would be really pleased if you could reflect that back to your teams on the ground. But I just now want to go back to the report. Committee, are we happy to not just note the report, but thank everyone involved for the sterling work that they are doing and will no doubt continue to do to make sure Staffordshire is vaccinated? Are we in agreement with that process?
Absolutely, Chair. Absolutely.
Thank you. And so it just leaves me to do a couple of things. One is we would like to see you again because the job will get more complex. Your ask of us will probably also get more complex, particularly when you look at the mortality rates in some of the lower down groups and trying to persuade them to take up the vaccine. I don't think that's for a while yet, you'll be pleased to know, but maybe in April. And otherwise, if you do have other things that you really must be doing, we would certainly understand. And thank you for everything that you are all doing as a collective and as individuals.
Thank you very much indeed. Thank you.
Thank you.
Thanks, everyone.
Bye-bye.
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 Thank you very much. Bye-bye.
So with committee's permission, looking at the agenda, I would just like to bring the work programme forward if we can. We could comment on the work programme, but I would like just briefly to invite Marcus Warnes, who I think is still with us. Marcus?
He's not chair. He's left the meeting, unfortunately.
Have we got Tracy with us?
Tracy's still here, yes.
Tracy, do you want to comment on the work programme?
Yes, Chair. I think it was already mentioned in the integrated care system briefing around the governing body of North Staffordshire clinical commissioning groups review around the hearing aids for moderate hearing loss in North Staffordshire CCG, and the governing body met on Thursday last week, and a briefing has been sent out to say that they have reviewed their position and people with moderate hearing loss now will be receiving the hearing aids on the NHS.
Thank you. We have that briefing. I will ask, which came in late on Friday. I'll ask Nick to circulate that round committee members.
It will be circulated this afternoon, Chair.
Thank you. That's most kind of you. And members will be mindful that this has been an ongoing issue for maybe 3 years, maybe 4. We obviously welcome the position from the Clinical Senate in reviewing that decision and extending hearing aids on the NHS to in North Staff's CCG area to those with moderate hearing loss. Thank you. So just finishing, thank you, Tracy, appreciate that. So just finishing the work programme, is there anything that anyone wants to pick up specifically on the work programme that we haven't referenced already? So on that basis, I would be pleased if members just want to keep giving us a bit of latitude so that we can add in anything which is COVID related as we go. Nick, is there anything else you want to say on the work programme per se before we just go back to the...
No. My only comment, Chair, is if members that are still in the meeting are happy with the work programme and are happy with the flexibility that you've requested regarding COVID-19, we take it as read. Just to make you aware, Chair, if we lose one more member, we're not for it.
Don't worry, it's lunchtime, but it was important stuff to talk through. So are we happy with that, members? Let's go backwards then to the final item, which is the district and borough health scrutiny activity. We can take what's on paper as read. Is there anyone who wants to give us any updates?
I think you may struggle, Chair, as most of the members now who would be reporting to district and boroughs have now left the meeting, unfortunately.
I'll invite David Latham.
Thank you, Chairman. Paragraph 8 on this one for me, please, Lichfield District Council. If you quickly scan read para 8, this is something that keeps coming up from various councillors where they want... I've given them answers to all of these questions, and I believe they are matters that should be dealt with locally. However, I keep getting challenged to bring it to your attention. George Bryan Centre, the CCG's performance, and I think that's probably a matter of little concern now, having heard that they may not be with us for much longer. And also the need for a permanent health centre in Burntwood. I'm not sure these are Healthy Staffordshire Select Committee issues. Your views, please.
Thank you. Joyce, I'm assuming you don't want to talk on this. I'm assuming you want to talk on something else. Is that correct? Okay, I'll take that as correct. So can I suggest that with your scrutiny team and Nick and myself, we just arrange a further follow-up conversation, go into some of the detail and then make sure that it's either picked up locally and there is a route forward for that with the right support from the right providers, and then or alternatively it's picked up centrally by Healthy Staffordshire Select Committee. It should only be really picked up if it is a cross-cutting multi-divisional area or multi-area issue, borough district issue, but we can do that separately if that is something you are happy with and providing committee are happy.
Yeah, I would. Sorry, you're talking to me, Lichfield.
Sorry, yeah, David. Yes, sorry, yes.
Yeah, would greatly appreciate a bit of finality from yourself saying, look, Lichfield, you get on with this. At the moment, they're not listening to me.
That's fine. If we get a date in the diary, we can go forward from there. So that sounds like the right way forward.
I'll do
okay.
that, Nick. Thank you.
Yes, please. Yes, thank you. And then I've got Joyce Bolton, who I should have welcomed you to the meeting originally. Welcome, Joyce. The floor is yours.
Thank you very much, Chair. I just noticed from the reading that I was sent that you didn't have a report from our meeting for the 22nd of December about our last Wellbeing Select meeting. It's just to tell you that we had just had a verbal update from Chief Inspector David Wayne from South Staffs Police regarding crime and antisocial behaviour, and this was also supported by the Community Wellbeing and Partnership Officer Maggie Quinn.
Perfect.
That was all. Thank you very much.
Thank you, Joyce, and welcome. Look forward to working with you going forwards.
Thank you very much.
I think given the hour and no one else is indicating, it's been a long meeting. Hopefully members will have found that a useful meeting, some critical stuff for us going forwards. So that brings me on to the date and venue of the next meeting, which is Tuesday the 16th of March at 10 a.m. and that will be on Microsoft Teams. Members, thank you for your involvement.
Thank you, Chair.
Thank you.
Thank you, Chair.
Thank you, Chairman.
Thank you, Chairman.